Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Update 1. And with immense pleasure, I would like to invite Dr. Deepak Singla, who is Consultant Medical Oncologist, Indus Hospital, Mohali, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Okay, thank you, Geetika, for this kind introduction, and good evening, all. I would like to welcome all my participants and panelists for joining us and sparing their valuable time in this Friday evening. As we know that carcinoma lung is a global problem and it's killing around millions of people around the world. But we live in a time where the stage 4 carcinoma lung patients are living years together by the virtue of advancement in precision medicine in the form of immunotherapy as well as a targeted therapy. And to introduce to, and to begin with, and in the next 2 hours, we will be talking about the advancement in the oncology updates in the carcinoma lung. For this, first of all, we start with our senior and our teacher, Professor Pasricha, who is a senior histopathologist and head of the department in at RGCI, Rajiv Gandhi Cancer Institute, Rohini, New Delhi. Sir, over to you, sir. Thank you so much, sir. Yeah, Dr. Pasricha, please.
Yeah, thank you. Thank you for the kind introduction. Dr. Deepak, I am not heading the department. I am just senior consultant.
Okay, right, sir. For thoracic oncology, I mean to say. For
yeah,
thoracic. Yeah, okay.
So, can I share my slides?
Please, sir. Yeah.
So I'll be talking about the new biomarkers in the management of NSCLC. So as we all know that 90% of the lung cancer, they are basically NSCLC, and the great majority now, even up to 60% are adenocarcinoma. And the role of the pathologist in this current era is not only just to diagnose the lung cancer, but also to find out the predictive biomarkers so that the patient can be put on the targeted therapies. And why it is important? Because survival of the patient with the drivers can be seen in this mutation consortium when the patient were put on the targeted versus no targeted therapy. So this consortium analyzed 733 patients for the 10 genes, and we can see in this graph then that there is a good prognostic separation of the curves when the patient were put on the targeted therapy, this orange curve, versus when the patient were not put on the targeted therapy and when no driver was identified. So the consortium demonstrate that the best outcomes they are seen in the patient with identified drivers placed on targeted therapy with the median survival of 3.5 years, which is commendable for the medical oncologist. So majority of these common and uncommon driver mutations now they are targetable with the FDA approved agent or which are on the clinical trials. Like recently we have got approval of, for example, EGFR exon 20 insertion mutations, for HER2 trastuzumab deruxtecan, and for KRAS, sotorasib, and adagrasib. We have to realize that there is a potential application in the uncommon mutations which are recently described. So my talk will be focused more because the topic that has been assigned that the recent biomarker. So I'll be speaking something which is beyond EGFR and ALK. We see that there is a potential application in the uncommon mutation beyond the EGFR and ALK like ROS, BRAF, MET, B2, and that makes more than 15% in all, so which is a good number. There is an evolution of the therapy in the lung cancer, and it is not a single disease. Now we have seen that with the passage of time that it's a spectrum of many diseases now. So a biomarker testing in the lung cancer has always been a moving target. In 2019, the ASCO recommendation has basically divided the testing into two broad categories. One is the minimum necessity, that is the must-do test, which must we have to do, and the other is the recommended, that is should-do test. We should do as far as possible, considering our armamentarium. The same thing was also reinstated by the NCCN in 2021 guidelines that beyond the EGFR ALK, one has to go for the ROS, BRAF, and these other rare mutations which are targetable, and also to do PD-L1 expression upfront. I'll be starting with the ROS1. So the ROS1 oncogene is a receptor tyrosine kinase seen in 1 to 2% of the NSCLC show this fusion, and that is because of the translocation between the ROS1 and the other gene. The most common is CD74. So basically that leads to activation of the downstream oncogenic pathway, which leads to tumorigenesis, and these tumors, they are sensitive to ROS1 inhibitors like crizotinib and entrectinib, which has been FDA approved, who are treatment naive or post chemotherapy. ROS1 rearrangement, they are frequently associated with the young patient, women, never smokers. Predominantly, they show lipidic, acinar, or a solid carcinomas, or even a signet ring cell morphology, and they are TTF positive, and they are seen in advanced stage, and they have a higher frequency of brain metastasis. So this is the bird's eye view of the various fusion partners, and 90% they comprises of the CD74, ZR, CDC4, M3, SLC34A2, and GOPC. What are the methods of detection? FISH break apart is recommended as a single gene assay if you are going for a single gene, but NGS is recommended as a part of multi-gene assay. Immunohistochemistry is very effective way of screening. Like we are using this antibody, which is a recommended antibody D4, D6 from cell signaling. But the bottom line is that all positive immunohistochemistry cases must be confirmed with the FISH analysis before starting on the targeted therapy, unlike the ALK positivity. Like on IC, if you get ALK positivity, straight away upfront, subsequently we can go for the treatment. But for ROS, we have to confirm it with the FISH analysis. So this was the case showing the micropapillary pattern, and which was ROS positive. You can see the strong and diffuse expression of ROS, which was also showing the rearrangement. Into the BRAF mutation, so it is a downstream signaling mediator of the KRAS that activates the MAP kinase pathway, and these mutations are observed in 1 to 3% of NSCLC. The mutation occur at the V600E position of exon 15 or even outside the domain. And NSCLC patient who progressed on chemotherapy, the combination of BRAF and MEK inhibitor, that is dabrafenib plus trametinib, has been approved by FDA. And the preferred testing method, if you're going for a single gene, is a PCR, but the preferred is the NGS, which is a multi-gene assay. And these were the initial encouraging trials that have shown the trials, and the dabrafenib plus trametinib, which showed that they could represent a new targeted therapy with a robust anti-tumor activity and a manageable safety profile in the patient with previously treated or untreated BRAF V600E mutant NSCLC. Then to the another important mutation, that is the MET exon skipping mutation or amplification, which basically causes a dysregulation of the MET pathway. So basically, MET is a proto-oncogene that encodes the tyrosine receptor kinase, that encodes the tyrosine kinase receptor for the ligand, which is the hepatocyte growth factor. So here in the diagram, you can see that when there is a splicing abnormality, that exon 14 is skipping. So we can see that in the messenger RNA transcript that there is no exon 14. So that leads to the this protein. So the important component is the Y1003 protein. So this now is missing. And this is a very important component of this protein, the receptor, because it is required to bind with the CCLB for the ubiquitination pathway. So what happens when there is exon 14 skipping mutation? So once there is exon 14 skipping mutation, so this protein is not formed, so there will be no ubiquitination. So that will lead to a constitutive activation of the tyrosine kinase pathway. So that leads to tumorigenesis and uncontrolled cell growth. So when to anticipate? So if on the morphology you have this sarcomatoid growth pattern, which is TTF1 P40 negative, cytokeratin positive. So we label it as a non-small cell carcinoma, carcinosarcomatous differentiation. This morphological pattern may warrant an upfront MET gene testing. What are the characteristics of exon 14 skipping mutation? They are seen in 3 to 4% of all the metastatic NSCLCs, and they can be associated with MET amplification and the copy number variants. Commonly seen in female, the elderly, and non-smoker, and can be seen in smoker also, and highly predictive of response to MET inhibitors. The FDA has approved capmatinib, tepotinib for the metastatic NSCLC, whose tumors have a mutation, exon 14 skipping, as detected by FDA approved test. And also, MET exon 14 is an independent, it's an indicator of a poor prognosis, having a shorter overall survival in the NSCLC, where that has been established long back. We can see this Kaplan-Meier survival curve. There is a significant prognostic difference for the patient who are having a MET exon 14 skipping mutation. Foundation 1, the companion diagnostic, is a DNA-based method for the detection of the MET exon 14, and the FDA has approved the Foundation 1 companion diagnostic to aid in the detection of MET exon 14 in the tumor tissue. problem is that the RNA-based sequencing is actually now preferred over the DNA-based NGS because RNA sequencing that has an advantage of encompassing all the causal genomic events that actually lead to exon 14 skipping, hence being much more sensitive. RNA sequencing detects the fusion of exon 13 to 15, and in one study that was published in JTU, approximately 60% of RNA positive results were found to be false negative in DNA assays. So I can explain it in a more simplified way. Like this is a normal RNA. We can see that exon 14 is intact over here. So this has a number of base pairs. So what will happen if exon 14 is skipped? So now exon 14, the 140 base pair are assigned to exon 14. So when there is an exon 14 skipping mutation, so we will have n minus 140 base pairs. MET amplification is also a mechanism of MET dysregulation. The amplification is regarded as a primary driver gene and also one of the main mechanism of tyrosine kinase resistance EGFR. And depending upon the assay and the positivity cut point used, the occurrence of the de novo MET amplification is about 1 to 6% in lung cancer, and many studies have shown associated MET amplification with the shorter survival. However, the high amplification, the ratio of MET to SEP7 ratio of more than 5 appears to be a strongest predictor of the true MET-driven tumor that is seen in less than 1% of lung adenocarcinoma. And again, the MET amplification is associated with poor survival in NSCLC patients. And we can see from this Kaplan-Meier survival curves that so MET is also a co-driver in NSCLC. MET amplification in EGFR mutant NSCLC comprises of 5 to 15% of the EGFR mutated tumor that have actually required resistance to TKIs. And a liquid biopsy might be a very important tool to use in this situation to detect the secondary mutation without repeat biopsy and discomfort. Now, with the osimertinib as the first line choice, the spectrum and association of MET mutation will remain to be seen in near future. To another recent described mutation, that is the exon 20 insertion mutation. Among the NSCLC patient with EGFR mutation, approximately 4 to 10% of the patients, they have exon 20 insertion mutation. However, the demographic of the patients, they are similar to those of the patient with the classical responsive EGFR mutations. However, these mutations, they have a lower overall survival and PFS than those with the common EGFR mutations. And exon 20 mutations, they are resistant to typical EGFR TKIs. Regarding the testing method and treatment, heterogeneity of EGFR exon 20 insertion mutation is quite high, and PCR is not at all recommended as it is not sensitive. You can miss a lot of mutations in this, and NGS is definitely recommended, and 2 targeted therapies have been approved by the FDA, that is amivantamab and mobocertinib. They are approved for the treatment of the patients with locally advanced or a metastatic NSCLC harboring EGFR exon 20 insertion mutations that has progressed after a prior chemotherapy. So, NCCN guidelines have also stated that targeted PCR-based approaches may actually underdetect the exon 20 insertion events, and NGS is preferred. And one study has shown that even up to 58.6% of these mutations identified by NGS, they were actually missed by the PCR, and out of the 17 most common EGFR exon insertion mutant variants, only 4 can be identified by the PCR. Coming to HER2 mutation, the HER2 or the ERB2 is a EGFR family receptor tyrosine kinase. It is seen in 1 to 4% of NSCLC tumors, common in non-smoker females, and majority are in-frame insertion in exon 20, and few cases they may show point mutations also, and they are detected using PCR or NGS. And early phase clinical trials suggest that the patient with the tumors harboring these mutations who progressed on chemotherapy, they may respond to trastuzumab-based regimes. However, the trials have demonstrated no significant benefit for the trastuzumab for HER2 amplification. RET rearrangement RET gene encodes a cell surface tyrosine kinase receptor. The RET rearrangements are identified in 1 to 2% of lung adenocarcinoma. They are seen in young never smokers. Again, the testing modalities, because the incidence is low, so NGS is recommended as a multi-gene assay. The FDA has approved selpercatinib and pralsetinib for the metastatic RET fusion positive NSCLC, and encouraging results were seen in the multi-cohort open label phase 1-2 Libretto 001 study. Coming to the RK fusion, the prevalence is around 2%. In NSCLC, larotrectinib and entrectinib are the 2 FDA-approved oral TRK. They are inhibitors which are approved in a tissue-agnostic fashion, and the recommended method is again NGS as a multi-gene assay. And however, the IHC is available, like we are having this immunohistochemistry marker with us for the screening, but again, it has to be confirmed with the NGS, and the IHC is only for the screening, which shows a strong cytoplasmic staining. However, the standalone tests are not cost-effective or feasible. The efficacy of larotrectinib has been shown in early phase clinical trials, and out of the 12 patients with a lung tumor, 9 experienced a response to treatment with a response rate of 75%. Coming to the NRG1 fusions, the fusion involving the neuregulin-1 gene are rare, less than 1%. The recommended method again NGS, and data have suggested a poor activity of chemotherapy and immunotherapy in these fusion cancers. And a series of 5 patients who received afatinib therapy for NRG positive lung cancer, they demonstrated 4 partial radiographic response out of the 5 patients, with the 3 of these lasting over 18 months. The other targeted therapeutic against the NRG1 fusion are in clinical trial development, such as seribantumab. Coming to the KRAS mutations. So coming to the KRAS mutations, the activating KRAS mutations, which activate a number of downstream signaling pathways, they are observed in approximately 25% of lung adenocarcinoma. The recommended method is the NGS, and multiple agents specifically targeting the KRAS G12C mutations, which is seen in approximately 50% of the KRAS mutation in NSCLC, they have emerged. And sotorasib is approved by FDA for this G12C mutated KRAS for the locally advanced or metastatic NSCLC who have received at least 1 prior systemic therapy. So we have seen that NGS is now preferred over, with the passage of time, we have realized, and that NGS is now preferred over the single gene assay because it's tissue proficient. 10 nanogram of input of DNA and RNA is sufficient. It's also resource proficient. You have a 1 experiment, 1 test, 1 platform. The variant allele detection cutoff is around 5%, and hence it overcomes the problem of the low tumor fraction also. And besides that, it gives you the types of alteration, whether tier 1, tier 2, tier 3, and depending upon the type of the alteration, the patient can be straight away put on the targeted therapy and even can be recruited in the clinical trials. NGS can use plasma also as a sample, and there is a FDA approval for analytical, clinical validity, and clinical utility. However, that is a turnaround time is still a problem. So optimizing the driver identification. So DNA-based sequencing, because most of the genomic breakpoints that lead to the gene fusion, they occur in introns. Therefore, assays are designed to detect the rearrangements or fusion must sequence introns. However, it's a tedious. The introns are known to frequently contain repetitive sequences that are actually difficult to assess by the NGS. So there will be a possibility that the genomic breakpoints may occur in the intronic region, which cannot be properly sequenced, leading to a false negative result. This is why RNA-based NGS, which is now getting more popular and has an advantage over the DNA-based NGS. So at RGCI also, we are using both DNA and RNA-based NGS now. And so for every tumor sample, we are isolating the RNA also. So sequencing can be focused on coding sequences instead of introns and has the reduced false negative cases, hence increased sensitivity with RNA-based NGS. However, the drawback is that we have to, this approach is we have to rely on the high reliance on the RNA quality, which can be poor in the clinical sample, particularly those with the formalin fixed paraffin embedded tissue. So the RNA quality, we have to be very meticulous to have a good RNA quality. So in a nutshell, these are the methods of the tissue testing in NSCLC. The DNA sequencing, they are ideal for the insertion, point mutation, and deletions. The RNA sequencing panel detects the fusion abnormalities. They are more sensitive for L-cross, RET, and TRK. And IHC is a good modality for L-cross and PD-L1. Regarding the biomarkers of immunotherapy, we know that there is no robust or a biomarker, but the work is still in progress. And these are the various markers at our disposal. And we can see that of all these markers like MSI, tumor mutation burden, and gene expression signature, it is the PD-L1 immunohistochemistry that has shown, which is a therapy-specific biomarker, which has shown a possible utility. And these are the indications it can be utilized for the immunotherapy for NSCLC. So for metastatic NSCLC, the first line it can be utilized, and also for the second or later line treatment, and also for the locally advanced stage 3 NSCLC as a consolidation treatment. So the role of pembrolizumab was established 3-4 years back, and it can be given upfront as a monotherapy when the PD-L1 expression is more than 50%. So these are the current standard recommendation in the first line. Pembro as a monotherapy when TPS is more than 50%, or in combination with chemotherapy when TPS is less than 50%. while in the second line, later line, the pembrolizumab, when the TPS is more than 1%, for nivolumab, any TPS will do, PD-L1 testing not required. Nivo in combination with the ipilimumab has been approved as a first-line treatment for metastatic NSCLC expressing PDL more than 1%. PLIC testing is an established predictive biomarker, not a very robust, but still the best we have. And this is the study I just published 2-3 months back, and which is practical considerations for the oncologist and pathologist, which was published in IJMPO. With the recent wealth of information from the molecular perspective, so there has been some recent updates that the diminished efficacy of the PD-L1 inhibition in STK11 and KEAP1 mutant lung adenocarcinoma, and that is affected by KRAS mutation status. So this was an important publication in the JTO, and we can see that when the STK mutation was, so this study involved around 13 or 1400 patients, and they found and that when STK11 mutations were seen in concurrently with the KRAS mutation, so the overall response rate was very poor, and the statistical significance was very high. But when the STK mutation was seen in the without the KRAS mutation, that is with the wild type, there was no statistical significance. The same with the KEAP1 mutation. So when the KEAP1 mutation was there concurrently with the KRAS mutation, so we can see that the objective response rate was very poor, and that was significantly quite high. So STK11 and KEAP1 mutation confer a worse outcomes to immune checkpoint inhibitors among the patient with the concurrent KRAS mutation, but not among KRAS wild-type lung adenocarcinoma. This finding was further supported by the transcriptomic data from the Cancer Genome Atlas database, revealing the existence of unique transcriptomic profiles of the patient with STK loss or KEAP1 loss in KRAS mutant lung adenocarcinoma, and that leads to several down-regulated pathway of antigen presentation and immune response. STK11 and KEAP1 mutation potentially be predicted outcomes to both chemotherapy and immunotherapy, and this is due to their pleiotropic effects on the cancer cell metabolism and immune system engagement. And conversely, STK mutation does not seem to affect the efficacy of KRAS G12C inhibition in patients with KRAS G12C mutated NSCLC receiving sotorasib. To conclude, there is an extensive role of biomarker testing in metastatic and advanced NSCLC adenocarcinoma. Broad molecular testing, NGS, and liquid biopsy have already made their place for the biomarker assays as a frontline. And multidisciplinary communication is very essential for the quality information within the required frame time to maintain the turnaround time, and that too at the judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and post-analytical steps. Thank you.
Yeah. Thank you, sir. Thank you. And it was a really wonderful talk, and it's a really an eye opener for us. Sir, I just wanted to ask one question, sir. Sir, in RGCI, it's a standard practice to send an NGS on first biopsy after obtaining the histopathology report, and whether you are combining with DNA-based NGS or plus you are combining with both DNA plus RNA. And
we are doing DNA and RNA combined upfront, and as I've alluded to in my talk, also like for the fusion, like the ALK, ROS, and these REDs. So for that, the RNA base is much more sensitive. And regarding your first question, that upfront NGS, yes, sometimes the cost and the turnaround time is still a problem. So depending upon, like if the patient is a non-smoker, she's a female, and you have a lipidic or that pattern where you can anticipate, or you are having a signet ring cell morphology. So if you are anticipating that you are having, there is a probability of detecting a EGFR or ALK. So depending upon the probability of the clinical presentation. So many times we are getting a single gene assay also, like EGFR, ALK, ROS upfront. And if there is no mutation detected, then they subject the patient for NGS.
Okay, and what is, as you are doing, sir, in-house only in the RGCI itself, and so what is the turnaround time there in your center?
It's around 2 weeks at least.
At least 2 weeks. Okay.
Yeah.
Okay. Right. Okay. Thank you so much, sir. Thank you for your valuable time and wonderful presentation. And Geetika. So our next. Geetika.
Sir, our next speaker is Dr. Deepak Bharti, sir.
Yes, I just invite you. Good evening, Deepak. Are you here? Are you there?
Good evening, sir.
How are you, Deepak?
Fine,
Yeah,
fine, sir. Fine.
so I would like to invite our next speaker, Dr. Deepak Bharti, who is a consultant at Mata Vaishno Devi Narayana Hospital at Katra. And he's our, when I was working in Artemis and he was with us, he was as a DNB student. So our Dr. Deepak will take us through the, what is the evidence-based approach towards the stage 3 non-small cell lung cancer. Dr. Deepak, over to you, sir.
Thank you,
Deepak,
sir.
over to you. Yeah.
Thank you, sir. Just give me a minute.
Yeah, no problem. Take your time.
My slides are visible.
Yes, yes.
Yes, sir.
Shall I start?
Yeah, please, Deepak.
Okay.
Put
Good evening,
your
everyone.
camera on also. Put your camera on. I mean,
Just a minute.
yeah.
Where's the option is? So I'm not.
Can I run from my side, Deepak, sir?
Okay. Okay, you can run.
Sure. Deepak, sir, is visible?
Yes, it's visible to me.
You can
So-
start, sir.
So you can share the slides. And so control is with you or with me?
Can I share remote control?
Yes.
Sir, control from your side or our side?
From my side.
Okay, wait, sir.
Okay, no problem. You can if you want.
Now you can access from your side, sir.
No. I'm not able to run. Okay, it's better that you can control my slides. I will just say next and please. Is it okay with you?
Yeah, sure, sir.
Okay, fine. Good evening, everyone. Firstly, I want to thank Dr. Deepak Singh for inviting me for today's discussion and AstraZeneca for giving me opportunity to discuss very important topic regarding lung cancer, and it's a very important group, stage 3, which is as everyone knows, is a very heterogeneous group, and its survival based on whether patients 3A, B, or C, and even after so much improvement in this with chemotherapy and radiotherapy, still we are not able to achieve that survival benefit which are achieving with colon or breast or other cancers. So science has evolved and they have translated the things into the whether from the targeted therapy or newly designed half a decade back immunotherapy. They have used its existence and they decide to put the role of immunotherapy to this aspect of group of lung cancer, and in the form of a very landmark trial with the name of Pacific. And just I want to share how it has evolved and how the data has evolved in the last 5 to 10 years. So basically, I will start with lung cancer, the burden in India. As I already noted, it is the second most common cancer, especially in males in India, and it is the 72,000 in 2020 Globocon, and 66,000 deaths are there among 72,000. So it has 91% death versus incidence ratio is there. So this keep this thing very important so that we can increase the survival to our patients, because even after this chemotherapy, radiotherapy, achieving all the things, we are not able to achieve more than 25% 5-year survival in this group of patients. So next. Okay, so point that how we'll manage the unacceptable stage 3. What guidelines say that 3A we can operate, and some 3B with N2 less than 300, we can also pay that. The patients who are not able to get paid whether to any of the other reasons and who are going towards definitely CTRT. How will you approach this patient? This schema will tell us, and it's obviously a multidisciplinary team will work with the name of medical oncologist, additional oncologist, pulmonologist, surgeon, and pathologist. All will have to sit together in a multidisciplinary tumor board, and we will decide the fate of patient. How will you approach to every individual patients, what stage it will be, and what test we needed that we need to go underwent PFT, bronchoscopy, whether PET CT, and in the 2 years back the guidelines are updated, and there's a role of brain MRI is there in stage 3 patients, even in stage 2 patients, that upfront we have to do brain MRI to pick up incidental brain metastasis. And regarding mediastinal lymph node evaluation, it will change the stage of patient and the survival benefit, and some patients can underwent surgery or radiation. It will depend on the nodal status of this patient. And point is that if we start the patient on treatment, there are two aspects, whether we go for concurrent or sequential. If someone is fit, we can offer concurrent because concurrent has a very definite data and very important safety profile as per to sequential chemoradiation patient. And how the data has evolved and favoring concurrent, I will show in my next slide. Next. Okay, these are the list of trials which are both for concurrent sequential, out of which we are showing the progression-free survival and overall survival in the name of Proclaim or RTGO 0617. Multiple chemogenes are used: etosis, vinblastine, pemetrexate, vinorelbine. But if you ask me, in what we use in clinical practice, if someone is with scammers, we are using Paclitaxel doublet, and if someone with adeno, we are using PEMCIS or PEMCAR doublet, depending on the fitness level of patient and platinum eligibility. And what we are seeing that even after combining both the things, we are achieving PFS maximum 11.4 months, and with overall survival, median survival of 25 months, touching 2 years. So that will make this group very important. Why we are not achieving after giving definite treatment, that they are getting maximum 2 year survival benefit only. And just see this sequential, that the survival is 14.6 months only. That's why, as per today's scenario, CTRT is standard of care. But to anyway, in some patients we are not able to give combination regarding toxicity profile or comorbid illness, we can use sequential regime also. Next. So the point is that what make this stage 3 as unmet need. Point is that even after giving CTRT curative intent, we are getting 40% local regional recurrence and 50% distant metastasis will be seen. And even after all things, what I'm telling you, 5 year survival is touching from 15-25% is there, and we median PF is 8 to 12 months. So this make this group very important to hit on why we are not achieving the survival and what new can be done and how we can improve the survival of our patient. But to improve the survival, they have made a trial in the form of Pacific, which I'll discuss in future slides. Next. Okay, these are initially what they wanted. They tried that if patient has completed CTRT, we will add on the treatment and we will give consolidation chemotherapy, whether 1, 2, or 3, or 4 cycles depending on the chemo what they are using. But just see they are not achieved significant PFS and OS. Just the hazard ratio of 0.91 and 0.98, 1.3, all is there. Even after adding the more treatment in the form of consolidation chemotherapy, we are giving more and more toxicity to our patients and not achieving the survival which we want to achieve in these patients. Next. So okay, no phase 3 trials have shown any OS or PFS benefit in this group of patients. Next. Okay, so what they have shown that initially they have tried sequential RT versus RT. They have found benefit from sequential CTRT, but when they have added RT with concurrent, and they have shown OS benefit. In all other things, whether they are adding induction chemotherapy or we are adding consolidation chemotherapy, there is no OS benefit has been seen apart from all the trials whatever is there in the literature at present. Next. Okay, so just to improve the outcomes both in PFS and OS, what they have tried, CTRT is considered standard therapy for patients with good performance status, while sequential remain an option for patients with marginal performance status. It's purely based on performance status of patient. To improve prognosis, further strategies like increasing radiation doses, induction chemotherapy, consolidation, all they have used, but all are in vain because they have not found any significant OS in the patient. So what they have shown that 5 years back, this chemotherapy come with a bone. Already they are comes in stage 4 on metastatic patients, but then they have put the indications in neoadjuvant adjuvant setting, and also they have put the indication in the form of maintenance treatment. They have tried the immunotherapy after completion of CTRT, the patient who have get the response, minimum partial response, and then they put the patient on immunotherapy. Next. Okay, so this is a trial which we are going to discuss. This is with the name of Pacific. Is a phase 3 randomized double-blind placebo-controlled multi-center international study. So basically, it includes patients, all patients of stage 3 or unstable patients they have added. Mostly they have received CTRT, whether sequential or concurrent, and almost 30% of patients they have received induction chemotherapy more than 2 cycles, and PS should be 0 to 1, and life should be more than 3 months, and all patients have been used in the archive tissues. They have used the PD-L1 status also. Just more point I want to hit that they have segregated the patients from day 1 of completion of CTRT to 42 days. What the implication of this is there, I will discuss in my future slides. Then they have randomized the patient to 2:1 ratio, durvalumab, standard 10 mg per kg every 2 weekly for up to 1 year. They have included 476 patients and placebo 10 mg per kg, and they have kept the primary endpoint in the form of PFS and OS. So this made this trial because they have included OS also a primary endpoint, and response rate, safety, and PROs, all things are there as secondary endpoints. Next. Okay, so this is well balanced and well matched. Both the groups, durvalumab and placebo, in the form of age or sex, race. And just I want to hit one point that 25% of patients in immunotherapy arms are Asian population also, because we have seen in EGFR that our Asians are behave differently and tolerate differently, but they have also got 25% Asian population in the subset, and all 3A, 3B, and other patients are also, majority are 3A and 3B, and 6% patients are EGFR mutation positive patients are also there in passive trial. Next. Okay. Although it is not based on segregated by PD-L1, but they have segregated the PD-L1 expression also in the form of tumor special less than 25% or more than 25%, and prior chemotherapy. As I told you, 25% patients have received induction chemotherapy before heading towards concurrent chemotherapy, and both the histology they have included. Smoking status also taken, and doses of radiotherapy also they kept into consideration. And just see, 2% patients have shown the complete response after CTRT, and 50% have shown the partial response. And minimum criteria is stable disease, what they want before putting this patient into this trial. And almost 27% patients have received induction chemotherapy before heading towards, and mostly they are 3B or 3C patients are there. Next. Okay. Just to segregate the data, total 711 patients they have received concurrent CTRT. Out of them, 191 have received induction chemotherapy. Just to downstage the patients so that they can tolerate the radiation therapy, just to include in the radiation field so that they have less number of toxicity side effects are there. And almost 99.7% have received CTRT prior to start of chemotherapy. This immunotherapy. Next. Okay, this is the Kaplan-Meier curve, what they are telling that even after 60 months, 5 years, 43% patients are still alive, and 33.4% in the placebo arm, with hazard ratio of 0.72, 28% benefit in the mortality risk is there. And just I want to highlight one that previously what data I am showing that 25% patients are getting benefit survive in the 5-year overall survival, and with this scheme they are doing 43, so they are touching 15% survival benefit is there after using this immunotherapy in this indication. Next. First and only improved immunotherapy to 43% OS at 45 years. No other trial has matched this data till now. Next. Okay, this is regarding the PFS. So we have found that 33% patients are getting prognosis versus 90%. So we are having 14% benefit in PFS with hazard ratio of 0.55. It's also wonderful that 45% mortality benefit in progression survival is there in this subset of patient. Next. So similarly, 33% benefit in PFS after 5 years with this IU. Next. Okay, so these are subgroups. Just all the subgroups are taken: smoking, disease stage A or B, histological type, all the things are there. Just see, all the subgroups are getting OS benefit in the favoring the durvalumab arm. Next. Similarly, in the PFS, no one is crossing the line of infinity, and all are crossing favoring towards the durvalumab arm in all the groups. Next. Okay, so point is that subsequent therapy. We are saying that patients who are getting the durvalumab as a maintenance therapy, those who get progressed, just see 42% of patients still able to get subsequent treatment options as compared to 54% in the placebo arm. This difference make it more valuable option that we can use future whether chemotherapy or target therapy in the future lines with after using this group of patients. This is 54 versus 41 after using immunotherapy. Next. Okay, just see pattern of disease. Point is that whenever patients put on any treatment, just we want to see that patient who get progress, in which subset of patient and what progression is there. We have found that 36% of patients in rural are getting the intrathoracic only. Local regional progression is there, but vis-a-vis 7% extrathoracic and touching 2% both intrathoracic and extrathoracic, which is comparable with placebo. Placebo has 48% intrathoracic versus 13%. And this is the data for intention to treat population. And when we see that subpopulation, we have 80% of patients who are getting intrathoracic. The point is that I want to highlight that the majority of patients getting the intrathoracic progression, and which make the patient to get whether surgical excision or re-radiation is possible or not. Some patient will gain the curative fit in the curative setting. Next. Okay, so this is what I want to tell you that patients pattern of intrathoracic is 42 versus 56%. Majority of patients in the durable are getting intrathoracic progression only, and with those patients are getting 25 months median time to get progression versus 9 months from placebo. Next. Okay, most important concept, most important is safety. As we all know that last 5 years we are very much familiar with the side effect profile of this immunotherapy drugs, although it can cause any inflammation in any part of the body, but majority of patients what we are reporting is the hypothyroid, and into 1 to 3% of patients we are found pneumonitis. And just see, as in this trial, 4% of patients are getting grade 3 or 4 pneumonitis, and if you ask me, grade 5 is 1% as compared to 2% in placebo. It's a very safe drug to use, and the time teaches us how to monitor and how to follow the drug and how we can manage the toxicity this immunotherapy. Next. Okay, so basically point is that what happened that this lung group stage 3 who are getting radiation, they are more prone to get the pneumonitis, radiation induced, and on top of when we add the immunotherapy, which asks us that whether our patient is at more risk for getting pneumonitis. This data doesn't support the same, because we found that only 4% of patients are getting radiation pneumonitis versus 2% in placebo arm. The patients are segregated in the form of less than 14 days or more than 40 days. That doesn't make any difference in this subset. More the hazard ratio and p-value is not significant, showing the same. And both the groups, whether we start the patient on this therapy less than 14 days or more than 14 days, doesn't make a difference. That's what I want to highlight, that this data segregated from day 1 to 42 days. Even if you found that patient is so fit that we can start immunotherapy on day 1 also, we are also right in that. And if you ask to put the patient on 42 days, they are also right, because in both the things, survival benefit doesn't differ, and both have the same and equal PF and OS benefit. Next. So this is the Pacific trial, what landmark study has shown, but we want to add our data from what real world is there, because we found that when we are seeing the landmark studies, we are found altogether different PFS, OS, and toxicity profile. So just to add on the things, we want to discuss 1 or 2 real world similar studies, what they have shown us. So this is a real world study based on Pacific in the form of Pacific R, the use of durable chemoradiotherapy, what PFS and OS they are including, just want to discuss. Next. Okay, so they are including on the base of same schema as in the Pacific. They have included the patient. They have started the study including France, Australia, Netherlands, Switzerland, and Belgium. All of the Western they have included. And what they have found that they have started the 5-year observation starting from December 2018 to 20. They have subset into the 3 groups. First after 2 years, then they have collected data after 3 years, and then after 5 years. And point is that they have want to discuss whether our patient, what OS we have found at 3 years in our patients. Next. As I told you, they have followed the patient for 39 months, and what they found that majority of the patients which are including these trials are less than 75 years, and 15% have received sequential and rest have received confirmed CTRT. And regarding smoking status, what I want to highlight that 9% are never smokers and 26% of current smokers are there in this group. Next. Okay, so more than 60% patients are still alive at 3 years. What I found, what we want Pacific, we have 42% at 5 years, and touching 60% they have shown at 3 years, which is a remarkably improvement as compared to placebo arm. And OS outcome were numerically better among patients who received within 42 days of finishing RT. So that's why they have kept from day 1 to 42 days and 6 weeks. In both the groups, they have found that the patients are getting improvement 60% versus 40%. Next. Okay, regarding PFS, they have found that 24 months PFS they have shown in this trial, and they have more than 40% patients are estimated to live at 3 years. PFS outcome is also better. Started less than 42 days of finishing RT. So in both the trials are comparably.
Dr. Deepak,
Yes.
Request you to conclude your talk in next 2-3 minutes, please.
Only 2-3 slides are remaining. Okay.
Okay, sir.
Next. Okay, so this is the as per to the what CTRT make a difference whether we would see a concurrent or sequential, and we have found that 65 versus 57. So what I told you that concurrent is the standard of care, and similarly they have shown that concurrent has a better overall survival rate as compared to sequential, that as this trial has depicted. Next. So comparison with clinical data, as we told that if this trial is not based on PD-L1 status, whether patient is 0 or 100, we can use this drug. There's no segregation or there's no limitation to use that, but they have conducted their data and they have found that the patient who have in the passive trial, they have 62% overall survival, and these patients are 67 in the PD-L1 more than 1%, and in less than 1% they have 54 versus 47. Although this doesn't make any difference to use this drug in PD-L1 positive patient, but what they have shown that in subgroup analysis they found that PD-L1 does make a difference, but not in the original trial. Next. Okay, safety outcome absolutely comparable in pneumonitis rates and other rates what we have seen in the Pacific trial. Next. Similarly, one more trial is there in the literature which has shown the real world outcomes in the same group. We will discuss 1-2 points only. Next. Okay, similar cohorts are there, concurrent and sequential. Next. Comparable results, the median age is 68, what we have seen 75 in that group, 41% adenocarcinoma, 50% squamous. Next. Okay, so regarding PFS and OS, just see there is 16.9 versus 9% in PFS benefit and 34 versus 19. What we have seen in Pacific trial, we have found 42 months and it has shown 34 months. So basically the original trial and what we have read about is almost comparable, or even we have found it more than that in the real world scenario, which will make us more confident to use this drug in this indication, and it will increase to the more survival benefits and make it a chronic disease. Next. Conclusion. Okay, so it's raising the hope for cure in non-small cell patients. It's a fibro survival is an important endpoint. Optimal CTRT followed by immunotherapy in the form of durvalumab till now is a standard of care in all stage 3 unstable patients, and converting stage 3 lung cancer to never progressing disease, which is and this is a abstract is there in the journal. They're showing that the patient at 5 years may become the more important endpoint at non-small cell becomes seen a chronic oncological disease, just like hypertension, diabetes. We are quoting a lifestyle disease. Next. Okay, this is the key takeaways in a nutshell. Median OS of 47.5% versus 29%, and there's no brain metastasis seen in 25% of durvalumab group versus 33% in the placebo group. Tolerability, as I told, is acceptable, and a favorable real world studies also favoring this indication. And all the things what I want to tell you, that no consolidation chemotherapy is better than consolidation durvalumab in this subset of patients, and we are good to use this drug in this indication. Thank you.
Thank you, Deepak, for this wonderful presentation. And yes, there was an unmet need for to improve the survival in the stage 3 non-small cell lung cancer patients. So thank you so much. And our next talk is next session is by Dr. Shubham Garg, panel discussion on the management of early lung cancer. Sir is Dr. Garg is a senior consultant of Fortis International Oncology Center at Noida, and he's a very great academician. So over to you, Dr. Garg, please.
Thank you, Dr. Deepak, for that kind introduction. I am just a clinician like you. We all try to be academicians, but clinical practice somehow takes the precedence. But I would just try to, I'm just trying to get this on the full screen. In the meantime, I'd like to introduce the panelists for us. Dr. Ashwin Phillips, Head of Medical Oncology at CMC Ludhiana, Dr. Sandeep Goel, Radiation Oncologist at Gurgaon, Dr. Nikhil Vaid, Radiation Oncologist at Artemis Gurgaon, Dr. Kanika Sharma, Medical Oncologist at Max Mohali, Dr. Sajal Kakkar, Head of Radiation Oncology at Max, and Dr.
Hi,
Purohit,
Shubham.
Medical Oncologist at Max Shalibar. Hi, everybody. Sorry. I hope all of us are here, or I didn't see Dr. Philip. Is he here, sir?
Yes, he's very much.
Hi, wonderful.
Yeah.
So,
I think he's in car. I think.
Sorry?
Traveling. I think Dr. Phillips is traveling. I think.
I can imagine. That's that time of the day. So, yes. So, I'm sorry, I am not. Oh, okay.
Sir, can I run from our side?
No. Let me run, please. Let me run. I'm
Okay,
just trying to save some time. So this is how the panel is set today. There is no surgeon on the panel. I'm surprised, considering early lung cancer, but I will fill that role of being a surgical oncologist. But we have two sparring teams, one of good sparring teams and equally sparring teams of medical oncologists and radiation oncologists. But I really doubt what's there to spar amongst these two groups when you have kept surgeon as a referee. And please, I am a true-blooded surgeon, blue-blooded surgeon, so I will be biased towards radiation. I'm sorry, but we have heavy radiation team to keep us in checks and balances. So I'll start with Dr. Nikhil. Dr. Nikhil, how do we define early lung cancer? I mean, what is those cases that you will take as a part of early lung cancer?
Mostly the early stage includes stage 1 or 2. That including stage 1 and 2 non-small cell cancers, tumor size probably less than 3 centimeter, and not invading the major structures away from the pleura and pericardium are the important structures.
Right.
So mediastinal node negative, proven. So these are the
absolutely. Dr. Philip, you differ or you'll be on the same side? Dr. Kanika, early lung cancer?
So yes, up to I think stage 2A, it's still early stage for at least us, where the patient cannot be taken for upfront. So yeah, up to 4 centimeter actually.
Right.
Yeah.
So just let me put a surgeon's point of view that even if it is N1, so I will not say that they are early, but they are really operable ones. We are actually defining early lung cancer, so N0 would be ideal, but even N1, because these patients would not change your management in terms of probably offering a surgery. So what we take is actually till 2B as early lung cancer. We remove the size criteria because T2, T3 is a very wide group. T3 includes including satellite lesions and including size more than 7 centimeters. So even those we try to avoid, but 2A N1 is something that is acceptable as early lung cancer. I would keep a case as one which will be the one which we'll keep on following. So this is a 68-year-old gentleman who came with ECOG-1, never smoker. And as in all our practice, they already have got a CT scan done, and they present with this kind of lesion in the right upper lobe, 3 into 2 centimeters. What would be your first approach, Dr. Sajal?
Yeah, so Dr. Shubham, now the 68-year-old gentleman, no comorbidities, and it's looking in radiologically speculated margins, peripheral lesion around 3 centimeters. So definitely we need to do the histological confirmation. So that would be the first thing to start with. So being a peripheral lesion, I think thoracic percutaneous biopsy should be feasible for this patient. And then the further metastatic workup, including EUS. First of all, let's do the, what about the nodes? Is the CT scan showing any lymphadenopathy?
Right. So actually, this is what I think. I think the imaging that should come would be a PET CT scan, which will not only define this nodules, but also the mediastinal nodes. Because even for a subgroup where we discuss mediastinal lymph node assessment, we need to have a PET scan. So PET scan, unfortunately, is irrespective of stage. Even for the early stage, you have to go with a PET CT scan. So like Dr. Sajal suggested, we got a CT guided biopsy which showed a adenocarcinoma, and the PET CT showed a right upper lobe nodule of size 1.8 with significant SUV uptake with no mediastinal node. There was no distant metastasis also. And this is how the PET scan image looks. So, Dr. Sandeep, what further information would you need to decide further management of early lung cancer? Dr. Sajal has already prompted on the need for a nodal evaluation.
I think we need to evaluate the mediastinum, and in case mediastinum is truly negative, we can do a EBUS guided FNAC. And if it is negative, then I think we can take it as true early lung cancer. And 68 years old with no other comorbid conditions, I think if the patient is willing, surgery should be attempted, or like patient should be counseled for surgery. Obviously, we have to do all of the workup, including pulmonary function tests and cardiac workup, to see whether the patient is candidate for surgery or not, or are there any conditions which makes patient unfit for surgery.
Amazing, amazing. I think that's the textbook answer, and he had me when he said that surgery would be the first option. But I think whenever we look at the patient in totality, we look at their comorbidities, we look at their PFTs, we look at their cardiac status, and obviously for completion of staging, we look at the mediastinal staging, invasive, non-invasive, we'll come to that. But yes, this is the right sequence of investigations, and Dr. Sandeep had crisply summarized them for us. Dr. Ashwin, what about the invasive mediastinal staging that we are talking about? What kind of one would we need in this kind of disease?
I think the PET CT and PET CT is good enough to tell our for the staging.
Right. PET CT is the first investigation for nodal assessment, and it has actually shown that there are no no mediastinal uptake. So is that good enough for you, or would you want some other kind of staging evaluation as well?
I don't think we need more than this.
Right. I think this is where the ESTS mediastinal staging algorithms helps us. It is this kind of subgroup of patient where it's a peripheral lesion, the size is less than 3 centimeters, and there are no radiological nodes seen on a PET CT scan, where you can probably get away without doing any kind of invasive mediastinal staging. But if there's any node which is suspicious on a PET CT scan, or the lesion is more central than peripheral, or it's more than 3 centimeters, then we would definitely need to get a EBUS done for mediastinal staging. The kind of patient that I have chosen for this type of meeting today is actually a very rare one, where you can avoid getting a mediastinal staging done. Most of the patients that we come across in our clinical practice, and I'm sure all of you would have some kind of nodes present, and any kinds of nodes, whether N1, whether N2, suspicious, any uptake, it is mandatory that we should get EBUS done. And if that EBUS is sufficient and you feel that the yield is representative enough, you can still go ahead with definitive management. But if you feel that the lymph nodes are significantly FDG avid, or they're significant size, then we do not rely just on the EBUS. We would even get mediastinoscopy done, whether a video assisted one or without the video mediastinoscope, to get a better staging done. But what about need for a MRI brain for early lung cancer, Dr. Sajal?
The tumor, if they're more than 3 centimeters, definitely we do MRI brain even in early stage lung cancers. So maybe less than 3 centimeters, we can probably avoid it, MR brain. But 3 centimeter or more, we definitely do MRI brain.
Right. And this would stay the same whether we are offering SBRT or whether we are offering a surgical resection for that patient, or would it differ?
No, I think MRI brain so we need to do, especially if you are doing before we opt for SBRT, better to do MRI brain.
All right. What about your clinical practice, Dr. Nikhil?
If tumor size is more than 3 centimeter, obviously we will offer MRI brain.
Right.
So yeah, if it less than 3 centimeter and nodes are not there, so generally we avoid.
Whether it's for surgery or whether it's for SBRT.
Yes.
Okay. So the literature, actually, this is a good publication which was done in 2020, and this is a meta-analysis where they actually say that of all the patients, they found that the lesion where they would actually MRI brain can be avoided is a T1A lesion, which is actually less than 2 centimeter. Anything more than that, a T1B lesion is also something where they would want to get stage 1B lesion is something where they would want to get a PET CT scan done. But there is we as surgeons actually prefer to get an MRI brain done, because again, surgery is something where it's a go and no go zone. You can't take a step back once you have already committed to it. So we would want to get an MRI brain done. Again, these are rare patients, less than 2 centimeters we rarely get, but most of our patients we would get a staging done. Does it matter to a radiation oncologist what the PFTs for a patient is? The patient is, anyways, not gonna go for a lung resection, and he has chosen to go for radiation-based therapy. Would you still go for PFTs for this patient?
Yes, actually, we'll go for PFTs. Because radiation itself has its own side effects. So as a baseline, we'll consider PFT for the patient.
Okay.
Pulmonary function test is mandatory before we do SBRT.
Yeah.
So this FEV1, FVC, and diffusing capacity of carbon monoxide, we need to do this. So there's a very high risk of radiation pneumonitis, especially in the central tumors.
Agreed.
This patient is a peripheral tumor, by the way, but yes, PFTs should be done always.
So whether it's central or peripheral, central, I agree. But for this patient, this is a peripheral tumor, we'd still go for a PFT?
But yes, we will do a PFT before SBRT,
okay.
And even in regular follow-up also.
Okay. Is there a lower limit of PFT where, we as surgeons have a post-operative predicted value of less than 40%, where we put a hard stop that this one is not going to come up for surgery? Is there a similar limit for radiation oncology where we say that, this is the lowest limit of FEV1 or FVC where we will not take up this patient for surgery, for SBRT?
Not exactly.
Not exactly. So PFTs that we are getting done are to see what reduction, then how does PFT help us?
As a baseline.
Mainly for documentation purpose. Because most of the patients who will have this lung cancer, they will have some kind of history.
Right. So
if they don't present with breathlessness at presentation and after SBRT they complain of breathlessness, then it will be very difficult to ascertain whether it is because of you will get the blame that because of radiation patient has got.
I agree.
It is wise to get a pulmonary function test done at baseline.
Right. So PFTs may not make a patient not acceptable for SBRT, but PFTs certainly are affected by the radiation that is conferred. This is more so in central tumors as compared to peripheral tumors. And this study shows actually that there was a significant reduction in the pulmonary function values by 3.6% at 6 months to 6.8% at the end of 24 months. Still, this is much more less than what we as surgeons would confer to a patient if we were to offer surgery to this patient, because any kind of surgery that I would do, the minimal surgery that I would start with would be a lobectomy at this point in time, and this may entail losing as much as at least 20% of the lung volume. So this is still a much better option for patients who have compromised lung functions to get done. What about molecular testing? Let me get Samit first. Samit, would you want to get some molecular testing done on this specimen? Remember, the patient has not been operated. he is adenocarcinoma, not been operated, not been offered SBRT. It is at this point in time, at the time of evaluation and decision making, how would molecular testing help us, or would you want to get a molecular testing done on this biopsy specimen right now?
Yeah, I think molecular testing is the need of hour, should be done upfront, especially in this patient who has adenocarcinoma histology, non-smoker he has been. So I think I'll get the molecular testing done for this patient, because there are many patients who have PFTs deranged and then they are not the right candidates for surgery. So if molecular testing is positive and we can identify certain hotspots, so we can give them those medications.
So let me ask you now, we have seen that this patient is probably fit for surgery or fit for radiation, pending whatever the patient wants. Now, when you know that the patient is going to go for surgery, still you would want to get the molecular testing done?
So how you can still get it done.
You'll still get it done. How is it going to change the management when the patient is going to be operated by getting to know whether he is EGFR positive or negative?
So there have been instances where there have been quite heterogeneity, even though it will not make any difference, right? My colleague said, but if you have a specimen, I'll get it done. Okay,
Dr. Ashwin, you were making a point.
Yeah, I was telling the same thing. If you're going to offer surgery to the patient, I will get a molecular testing after the specimen is removed.
Okay.
Molecular testing is okay when we're not able to treat the patient surgically.
All
after
right.
surgery, we are going to do if we have to start from.
Right. So Dr. Ashwin says that he'll get it after the surgery. Dr. Samit says he'll get prior to surgery. We have another medical oncologist, Dr. Kanika, on board. What's your thought process on this, Dr. Kanika?
So, sir, if the stage remains the same, that it is a 1.8 into 2 centimeter tumor, so there is no indication of any adjuvant treatment if post-operatively also the stage remains same. So I would not go for any further testing, because either for adjuvant immuno or osimertinib, if we are doing testing for that, there is no indication. That is also stage 1B forward. So if it's still a stage 1A disease, then I would not like to go for any other testing.
Dr. Kanika, we are talking about getting the biopsy, the molecular testing done prior to surgery. After surgery, depends on what the histopath comes, and then we'll take a call. But right now, by doing a molecular testing when the patient is planned for upfront surgery, would it change your surgical plan?
No, sir.
Right, no. So Samit, there is this ongoing, still I completely agree where you're coming from about getting a testing done. And I'm sure the Checkmate 816, where they are offering neoadjuvant immuno to all negative patient, is something where probably not for this patient because it's a smaller size lesion. Yeah. But tell me something, I am offering you a surgery where the specimen would come out. What if this was a patient who's going for SBRT where you are not going to get a specimen?
So in that instance also, I would like to get it upfront. In the previous scenario where you said ki surgery, the patient is undergoing surgery, then you will have an adequate chunk. So you can do it later as well, but I think it won't make much of a difference.
Right. What about you, Dr. Ashwin? If the patient is going to go for SBRT where you're not going to get a specimen, would you want to get the molecular testing done right now?
I do agree with what Dr. Samit has told. It's not going to make much difference, sir.
Right. So I think this is where it is important, because see, neoadjuvant immunotherapy, especially with the 816 trial, is there to stay for, it's shown good results, and it is there to stay for even for early cancers, not a 1.5 centimeter lesion, but definitely for a 3 and 3.5 centimeter lesion. But the question is whether we are going to offer similar kind of therapy to a small lung cancer who is probably unfit for surgery by offering SBRT, because we still don't have that data that neoadjuvant immuno in a or a neoadjuvant targeted therapy in a SBRT patient is going to help us or not, because the final result or the final desire of every oncologist is to get a better disease-free survival, to get a better OS benefit.
So, Shubham, just to interrupt, so what is the take home regarding the previous question? So, if a patient is going to get SBRT for the stage 1A disease,
right?
So, doing a molecular profiling, because probably we are not will not be offering any adjuvant treatment for this patient.
So I will give an answer to that, sir, because I have put this question to many forums, and the consensus is that it is better to, especially in case of a SBRT, it's better to get that molecular testing done right now, because later on, either you won't have the tissue, because post SBRT you will not be able to get that sufficient biopsy to put a testing done. One. Second, many times when the patients recur, actually they might just come with some pleural effusion where you don't actually get any tissue, or you get a single brain met, where you will not be able to get tissue enough for getting the molecular testing done. So I feel that the molecular testing, this is the right time to get molecular testing done.
Fair enough.
So are we planning to do a NGS for all the mutations or just a PDL1 and EGFR at this time?
I think the answer to that is not a complete NGS, not a very comprehensive one, but getting the basic ones done, EGFR, ALK-ROS and PDL1 should be sufficient, because these are the ones which are actually going to make difference if any of them comes positive. So not a comprehensive NGS. Obviously, if you have the facilities, you might think, but that is an overkill to get all of them done at this point in time. So this is to the radiation oncologists. If Dr. Sajal, Dr. Kanika and Dr. Sandeep, and they can take it in any order. If PFT is okay, cardiac functions are okay, what's the ideal treatment according to you in early medically operable lung cancer?
Surgery.
Surgery first. Surgery.
Dr. Kanika?
Surgery.
Oh, sorry, Dr. Kanika is the medical oncologist, but still Dr. Kanika, yes.
The surgery.
Surgery, thank you. So I will take this question and just try to wrap this thing up, that if the lesion is right upper lobe, the minimal surgery that we'll do is a right upper lobectomy with systemic mediastinal lymph node dissection, where we at least take these 3 stations of nodes, 2R, 4R and 7, but we would want to get as many nodes as possible, and this includes the 2L and 4L also. Any role of neoadjuvant therapy for early operable lung cancer, Dr. Samit? And I think you were hinting this with the molecular testing.
So yeah, with immunotherapy, they are coming up. There are trials which are underway. They are trying to give immunotherapy before taking up patients for surgery, and so that is one thing. So that's why I felt we should get the molecular testing, at least the basic hotspots upfront.
I completely agree, and I am a strong proponent of systemic therapy for lung cancers, because my operated lung cancers will live longer if they get the right systemic therapy, and neoadjuvant therapy seems to be working even for operable lung cancer. So I think why I agree with this is that by getting the EGFR, ALK-ROS, you at least find out that group of patients who are negative for all 3, and probably you can select a patient who will fall in the 816 arm, and you can offer them immunotherapy if they can afford it. That's a big if. I will skip this surgical question. This is about the sublobar resection, where we do a less than lobectomy. I will actually move on to, in the interest of time, towards non-surgical options, which is, so the problem with sublobar resections is that I just want to highlight this, that the tumor size has to be less than 2 centimeters. It has to be in a peripheral lesion, and the surgery that we are going to offer is a segmentectomy, which is a more skill-based surgery. You have to have a CT ratio of, when I say CT ratio, it means that the margins have to be equal to the tumor size. So if the tumor size is 1 centimeter, my margin on either side has to be at least 1 centimeter on each side, which means that I have to take out a 3 centimeter lung tissue. Now, as soon as it goes beyond 2 centimeter, my margins becomes 2 this side, which makes it almost 6 centimeters. And then the question of a segmentectomy does not arise. There are many non-inferiority studies which have come recently in the ELCC conference, and also the World Cancer Congress for the lung cancer, where they have actually said that segmental resections have found to be non-inferior to lobectomies. But if the PFTs are borderline, cardiac functions are borderline, and if the surgeons deems it to be medically inoperable, what would be the ideal treatment, Dr. Ashwin? Dr. Nikhil?
Yeah, see, if patient is inoperable because of any medical comorbidity or any other reason, then stereotactic ablative radiotherapy is the best option for him, for the
I-
patient,
I-
because yeah.
I completely agree. There's no doubt about it. Dr. Sandeep, can you just take us through in quick 2 minutes about stereotactic radiation? I just took out what I knew about SBRT.
SBRT is a highly conformal radiation therapy in which, ideally speaking, those patients who are fit for surgery are fit for SBRT. That means the tumor size should be small. It should be a peripheral lesion, although there are trials, there are studies which say even for central lesions you can do SBRT, but we know the complication rate would be higher and we have to reduce the dosage. And the best thing is the number of fractions are less, and the results, the local control is excellent with SBRT to the tune of 90% to 100% local control rate. Though the grade 3 toxicities are to the tune of 16 to 21%, but that is, I think, more or less acceptable. And if you compare with surgery, they provide almost equivalent results, though most of the trials, they favor surgery, other than some 3 trials which were favoring radiation. But I think the data was too small. So this Russell trial, STARS trial, and RTOSG 1021. So probably it is surgery is always kept a better choice for the patients. But yes, those patients who are inoperable or because of medical reasons, or if patient is not willing for surgery, then definitely SBRT provides very good results.
I completely agree, sir. I think you have summed it up well. So the head-to-head between surgery and SBRT is still open debate, but we have still good studies which are going on for medical operable ones, which we have for the lobectomy versus sublobar resection. We are looking at the Whaler trial and the Sabertooth trial. For the surgery versus SBRT, we still have the Whaler trial data and the Sabertooth trial data, which we are waiting, which will give us. So these were actually both randomized trials where they took not the medically inoperable ones, but the medically operable ones. This year, like I said, that the sublobar resection debate has been to some extent settled down by it showing a non-inferiority in randomized trials. Medical inoperable ones, so the surgeons are itching to get their hands up by offering a sublobar resections, and we are comparing it with SBRT in the stablemate trial. Let us see where it takes us. But I personally believe what Dr. Samit was mentioning about that molecular biology is the king, and we have to accept that there is going to be more and more role of molecular-based therapies coming into picture. Immunotherapy is there to stay. Targeted therapy, we have all seen the effects with osimertinib and in advanced cases. And we hope that we will get good lung survival. I thank all my panelists, and thank you again, Dr. Deepak Singla, for getting us all together and giving us this opportunity. Thank you.
Thank you,
Yeah.
Shubham.
Thank you. Thank you, Dr.
Dr. Shubham. Wonderful
Thank you, Dr.
discussion. And so thank you so much, all the panelists. And yeah, our next speaker is yes, Dr. Karnika Sharma. Yeah. So basically, our next speaker is Dr. Kanika Sharma, who is associate consultant at Max Hospital, Mohali, and she will be enlighten us about the role of alectinib in the ALK positive patients. So Dr. Kanika, over to you. Thank you for sparing your valuable time, and please go ahead. Yeah. Yes.
Just a minute.
Can I run from my side, Kanika ma'am?
Yeah, please. Can I control these slides?
Yes, ma'am, you can.
Exactly how? No, you can start the presentation. I just want the to control for changing the slides.
Ma'am, please, can you please check? Now you can access, ma'am.
So, good evening, everyone. So today I'll be discussing about the ALK inhibitors in non-small cell lung cancer. So we'll be discussing it. So we'll be discussing in the following heading, that is the overview, ALK testing, what are the approved agents, and about alectinib. Yeah. So as we know that the lung cancer is the second most commonly diagnosed cancer worldwide, and it is the leading cause of cancer-related deaths. And when we see the new number of cases per year, it is 2.2 million, and the new cases and the number of deaths, they are almost equivalent with 1.8 million deaths per year because of lung cancer. So when we see the subtype of lung cancer, it's a heterogeneous disease with various subtypes, that is the non-small cell, small cell, and the other subgroups. And in non-small cell also, there is adenocarcinoma, squamous, large cell carcinoma, and various other. Out of all these, the adenocarcinoma is the most common, accounting for 52% of the cases. So again, as we were discussing, the incidence and mortality both are relatively high in lung cancer. So as Sunil sir already discussed, the molecular testing, it is an important part of the routine practice. And as we were discussing also, that all the basic testing, that is the EGFR, ALK testing, they are the routine testing that is done in the clinical practice nowadays. So various methods are available depending on, so if we talk about the basic EGFR ALK cross, so all the modalities are available, that is the FISH, IHC, RT-PCR, and again, the most commonly used is the NGS based, in which we can detect the variety of mutations and PD-L1 testing upfront. So when we specifically talk about the ALK positive non-small cell lung cancer, so the incidence of these, it varies based on the ethnicity, based on the gender, and the smoking and non-smoking history. So if any female patient who is a non-smoker who is presenting with an upfront brain metastasis, then we automatically go towards the ALK testing first rather than the other testing. And when we see based on the regionality, that is the Europe, USA, and Asian population, the incidence of ALK varies, ranging from 3 to 7% of the cases. So again, it is a distinct subtype. So if we take in the particular range, it's around 5% of the patients that are diagnosed with an ALK positive disease. And again, as we were discussing, most of them, they are never former smokers, young patients, female, and it's a mutually exclusive mutation. So they do not have an EGFR or KRAS mutations. So when we talk about the ALK mutation, so the ALK gene in this undergoes a rearrangement within the chromosome, and there is that leads to a structural alteration of the chromosome in the expression of the ALK fusion protein. So ranging in the incidence, it is reported as around 7%, but actually in clinical practice, we see around 3 to 5% of the total lung cancer. So when we talk about the agents that are approved, so crizotinib was the first drug that was approved in the ALK positive based on the Profile 1014 trial, which has shown a median PFS of 10.9 months. And this is taken as a baseline with which rest all the drugs they are tested. And so the second one that came is the ceritinib based on the ASCENT-4 trial. And again, it is also approved in the first line. It has a median PFS slightly better than crizotinib with 16.6 months. But the issue with both these drugs are that these have a little bit poorer blood-brain barrier effect, and they are not as effective in patients with the brain metastasis. Then we go to the other generations of ALK inhibitors, which has a better brain permeability, and they are better effect in the patients with brain mets. So that is the alectinib, brigatinib, and lorlatinib. So alectinib, that is based on the ALEX trial, which we will discuss in details in the further slides. So it has a median PFS. So till now, it has the maximum reported PFS till the updated results of lorlatinib is not available. So when we see the crizotinib data, that is the Profile 1014 trial. So when it was compared to the chemotherapy, there was a benefit of around 4 months. That is 7 months with chemotherapy versus 10.9 months with crizotinib arm. And So, and when we talk about the 4-year overall survival rate, so it was significantly better in the crizotinib arm, that is 56.6% as compared to the chemotherapy, that is at only 49%. So coming to the side effect profile of the crizotinib, so the most common that we routinely see in the clinical practice also, they are the vision disorders, the diarrhea, nausea, vomiting, the edema that is commonly seen with this drug, and constipation. Recently, actually, I've seen one patient who developed renal toxicity because of crizotinib, and they have a renal dysfunction with bilateral renal cyst. And because of that, we have to shift from crizotinib to the second generation TKI. So it has a higher rate of vision disorder and GI adverse effects. So then when we talk about the ceritinib arm, that is the ASCENT-4 trial. So when it was compared with chemotherapy, again, there was a doubling effect. So the median PFS increased from 8 months to 16.6 months. And when we talk about the side effect profile of ceritinib, it has more of a GI related toxicity as compared to crizotinib. So there is more of diarrhea, nausea, vomiting. Otherwise, it's a well tolerated drug. So in this also, there was a greater impact on the quality of life with ceritinib when we compared it with chemotherapy. So as I was discussing before also, that both of these drugs, they are not that effective in patients with brain metastasis or in controlling brain disease, as they are actively exported out of the blood-brain barrier. So the blood-brain barrier, it contains the drug efflux transporter, that is the P-glycoprotein or breast cancer resistant protein. So they can actually eject the drugs out of the blood-brain through the efflux mechanism. So with crizotinib, it's a substrate of P-glycoprotein, and with ceritinib, it has both P-glycoprotein and the BCRP substrates. So then come the other drug, that is the brigatinib, based on the ALTA-1 trial, after which it was approved in the first line setting. With lorlatinib, the median PFS was longer. So with the CROWN study, now the updated 3-year data is also there. So when we talk about the 2-year and the 3-year data, so at 3-year also, there was a significant difference between the crizotinib arm versus the lorlatinib. So as compared to only 18.9% of the patient in crizotinib arm, it was 63.5. So around 2/3 of the patients, they have not progressed even at 3 years of the therapy. But the side effect profile is not that favorable with lorlatinib. So the most common that is seen is hypercholesterolemia and the hypertriglyceridemia. That is actually seen within the 1 month of starting therapy. So patient has to be started on some form of, statin and lipid lowering agents. And then the other problem is with this, the edema. So the problem that I'm facing with that lorlatinib is the cholesterol dysfunction and the edema that is usually seen in these patients. And again, the cognitive effects. So patients, they have a mood and speech effects. That is a major concern with lorlatinib. So then we are going to talk about alectinib. So what is the potency, resistance, mutation, the CNS penetration of this drug? So as we can see that there are various studies that have been done to prove that it's a effective first line treatment. So first was a phase 2 study that was done in an treatment naive patients in a Japanese subgroup, after which a J-ALEX trial, that was a phase 3 study, was done in a treatment naive patients who were ALK positive. So first treating in the Japanese patient, it was done in a global phase 3 study, that was the ALEX trial, which led to the approval in the first line setting. And now it's specifically in the Asian population, that is the Alicia trial. So discussing a little bit about the ALEX trial, which is a phase 3 study. In this, they have taken around stage 3B4 non-small cell lung cancer who came positive for the ALK mutation. All the patients were treatment naive who have a performance status of 0 to 2. So they were randomized in 1:1 ratio to alectinib, 600 mg twice a day versus crizotinib, 250 mg twice a day. And the drug was continued until disease progression, toxicity, withdrawal, or death. So they have also stratified the patient based on the CNS metastasis at baseline, whether based on the ethnicity, Asian versus non-Asian, the ECOG performance status. So based on the different cutoff data, so as we can see from 2017 till 2019, 3-year data, primary analysis, the first, second, and third exploratory analysis, the median follow-up and the effect, it has consistent results have been shown till the third exploratory analysis. So it has shown a comprehensive study, and in the various phases of the evaluation, it has shown benefit. So when we see based on the baseline characteristics, so when we talk about the CNS metastasis, so a large number of the patients, they have CNS metastasis at baseline in the alectinib arm. And all the patients, they underwent tumor imaging at baseline, and also every 3 monthly imaging was done to evaluate the CNS effects in these patients. So it is the first trial that has prospectively captured the evolution of a CNS disease with routine imaging every 2 monthly. So when we talk about the mature PFS data of ALEX, so around 3 years freedom from progression was seen. So it was 34.8 months, which is a very statistically significant from the crizotinib, that is 10.9 months, and with a hazard ratio of just 0.43. So even when we compared it with crizotinib, so if we can see, the 4-year data was not available for crizotinib, but 43.7% of the patients, they were alive and progression free at 4 years with alectinib. So when we see based on the subgroup analysis, so in the forest plot also, all the subgroup of the patients, they benefited with alectinib, and it favors whether it's an age, based on the gender. And when we talk about the CNS metastasis, so there is a significant benefit with alectinib as compared to crizotinib. So the magnitude of the effect was consistent in all the subgroups. Again, so as we were discussing, because of the good brain penetration, so when we see whether the patient is having CNS metastasis or without CNS metastasis, the benefit is consistent, and it has more than 2 years of median PFS benefit, even with patients who have a pre-existing CNS metastasis. As we all know, the patients who are presenting with brain metastasis, they have a poor prognosis. But with the advent of these latest drugs, even with the patients who have brain metastasis at diagnosis, more than 2 years also, they have not progressed. So again, as we can see with the CNS mets also at 4 years, 38% of the patients, they are event-free. And without CNS metastasis, it's up to almost half of the persons, so around 48% of the patients, they were event-free at 4 years also. So as we can see, the first-line treatment with alectinib, it reduces the risk of CNS progression. So there was 84% reduction as compared to crizotinib. So when we talk about the best overall response rates, so it was comparable with crizotinib. So as we can see, only rarely some patients, they have progressed. Otherwise, most of the patients, they have shown response with alectinib. And again, the duration of response also, it was 33.1 months as compared to 11.1 months with crizotinib. So with the risk of, again, CNS progression. So CNS progression without prior systemic progression. So with crizotinib, it was 68%, whereas only 18% with alectinib. So when we talk about the patients who do not have a baseline CNS metastasis, so when we talk about the CR and the PR rates, around 70%, 70 patients out of 88 patients, they have a partial response with alectinib versus 73 out of 93 patients that were treated with crizotinib. So the response rates were comparable, but the duration of response was significantly better with alectinib. So when we talk about the tumor reduction also, so more than 75% of the tumor reduction, it was seen in 43.7% of the patients with the alectinib as compared to 25% with crizotinib. So again, seeing all this data, so in the first line setting, it has a more than 60% overall survival rate at 5 years, which is quite impressive, and it is highest for any ALK positive therapy, and 6 out of 10 patients, they were alive at 5 years. So talking about the safety profile with alectinib, so when we compare both these arms, that is alectinib versus crizotinib, so the dose reduction, dose interruption, whereas treatment continuation, it was comparable with crizotinib. So it has a favorable side effect profile, and the dose reduction and the serious adverse effect did not differ between the two arms. So the most common side effect that is seen is, again, the nausea, diarrhea, vomiting that is seen with the patient's constipation, and fatigue that is seen with alectinib. So as we can see, the latest NCCN guidelines also in the ALK rearranged patients. So all the drugs, they are approved in the first line setting. So alectinib, brigatinib, and lorlatinib. And again, based on the cost constraint and everything, so ceritinib and crizotinib still remains the category 1 options in the ALK positive patients. So again, the molecular test, as it was discussed previously also. So all of these tests, they are recommended in the first line because all of these, they are the targetable mutations, and the drugs are available: EGFR, ALK, ROS, BRAF mutation, RET mutation, NTRK, MET exon 14, and KRAS mutations. So again, with alectinib, it has demonstrated a median progression-free survival of 34.8 months. It has effectively protects against and treats CNS metastasis. Again, it is the only ALK TKI that has demonstrated a clinically meaningful benefit in overall survival versus crizotinib, and it has a manageable safety profile as well. So concluding the ALEX data, again, it has shown superior PFS with a longer duration of response with impressive CNS efficacy. And again, it is a category 1 recommendation for the first line treatment in ALK positive patients. So coming to the other trial, that is the Alicia trial that was done in specifically in the Asian population. So again, they have enrolled patients with stage 3B, 4 ALK positive non-small cell patients who were randomized in 2:1 ratio to alectinib versus crizotinib. And again, they have further stratified based on the CNS metastasis at baseline. So when we see the baseline characteristic, again, they have taken CNS metastasis and it was actually comparable between the two arms. So again, when we talk about the median PFS with alectinib, it is 41.6 months as compared to 11 months with crizotinib. And again, it is consistent with that reported with the ALEX data. So when we talk about the CNS status, so either with CNS metastasis at baseline or without CNS met, there was a consistent PFS benefit. So even with CNS metastasis, the median PFS is 42.3 months with alectinib. Again, overall survival also. So the median overall survival is not reached in the alectinib arm as compared to the crizotinib arm, and it's a clinically meaningful improvement in the 5-year survival, that is 62.5% versus 45.5%. According to CNS status also, even with CNS metastasis, the median overall survival was not reached in alectinib as compared to 46.2 months. So when we see the post-progression therapy, so as the crossover was not allowed in this study, but after progression, 30% of the patients in the crizotinib arm, they received alectinib in the subsequent lines. And when we talk about the alectinib arm, so 61% of the patients, they have anti-cancer therapy after progression, and they have received a subsequent ALK inhibitor in the 36.8% of the cases. So again, talking about the safety profile of the patient, so it was comparable. Again, the dose interruption and it was favorable, and it was comparable with the ALEX study. And it was a consistent safety profile that was seen in the ALEX trial. So summarizing the 5-year update from the phase 3 Alicia trial. So it is Alecensa in the first line, it is approved in the 600 mg twice daily dosing, and it continues to demonstrate clinical benefit in the Asian subset also, with a median PFS of 41.6 months for alectinib versus 11 months with crizotinib. So it has a 3 times longer treatment duration compared to crizotinib. So that will be my last slide. And coming to the cost also, so this drug has come with an excellent patient support program also, so 1+3 patient support program. With that, the cost is around 1 to 1.3 lakhs per cycle for the patient. So more and more patients can be taken up for, because as we can see with the other trial also, with the first line, it is very important to give the best drug upfront to have the maximum response. So these drugs, when we see in the subsequent line, they have a not that better progression-free survival as seen in the first line setting. So thank you everyone for your patient listening.
Thank you, Dr. Kanika, for enlightening us regarding the ALK positive NCLC. But I just wanted to ask that how many percentage of your patients are getting ALK positive? Because since I came to this Tri-City for last 3 years, I hardly get very few patients, which are targetable or mutant.
Sir, I will say that there are the spurts of cases. So lately, we actually got 3 patients who were ALK positive. But yeah, if we talk about in the last 1 year, it is around 5 to 6 patients only.
5 to 6 ALK positive. And what about EGFR and others?
So EGFR also, it is not that. So when we talk about the 40 to 50% incidence in the Asian population, actually in the practice, it's 20 to 30% only with the EGFR also.
Okay, right. Okay, thank you, Dr. Kanika, for this fantastic session. So now we are coming to our next session. For the next session, I would like to invite our
Dr. Suresh Patel.
Dr. Suresh Patel for real world data in extensive stage small cell lung cancer. As we know that small cell lung cancer is a it's a deadly disease. Even in the limited stage also, it has maximum patients survive up to 1 year and maximum 1.5 years. So Dr. Patel is a senior consultant at Capital Hospital, Jalandhar. So he will be taking us through the journey of durvalumab in the case of extensive stage small cell lung cancer. Over to you, Dr. Suresh, and thank you so much for your valuable time.
Good evening, Dr. Deepak sir, and thank you for your kind words. I would like to thank Dr. AstraZeneca and their team for giving me the opportunity to speak on the topic of real-life clinical experience in management of small cell lung cancer. Am I audible?
Yes, sir.
Okay. Shall I share my slides?
Yes, yes.
Is my screen visible?
No, sir.
Is it visible now?
Yeah, right. Yes, it's visible now.
Can you, sir, make it full screen?
Is it visible now? Is the screen visible now?
The screen is visible, but your slides is it's not moving.
Is it moving now?
No, sir.
No, sir.
Yutika, do we have sir's slide?
Yes,
Is it
ma'am.
visible now?
Yes,
Yes,
sir, it
ma'am.
is visible. So you just click on enable editing, I think, then you will be able to.
Now it is in screen mode.
No, sir. It's not in full screen mode.
Can I run from our side, ma'am?
Yes, you can.
Sir, is it visible to you?
Yes, it is visible.
So you can go ahead.
I would like to thank Dr. Deepak Singla sir, and AstraZeneca and that team for giving me the opportunity to speak on real-life clinical experience in management of extensive stage small cell lung cancer. Next slide, please. So now we are going to have a discussion regarding a case, a 62-year-old male who is a smoker with history of 30 packs per year, presents with complaint of shortness of breath, hemoptysis, weight loss, and early satiety. On evaluation by the primary care physician, it was found to have that he has a massive hepatomegaly, and also his biochemical parameters are altered in the form of 3 times elevation in the ALT and AST levels. On scan evaluation, it was found that he has a left lower lobe nodule with mediastinal adenopathy and massive hepatomegaly. So a CT guided biopsy was done from the lower lobe of lung, and it was found to have small cell lung cancer histology, which was TTF1 positive and with a calcium level of 30 picogram per ml. Next slide, please. So what on diagnostic workup, we generally on our diagnosis evaluation, we go for biopsy along with bronchoscopy if there is central mass, along with biopsy, bronchoscopy guided. We also go for PET CT along with brain MRI. Next slide, please. Also, you can see that even NCCN guidelines mention the need of evaluation with PET CT whole body along with brain MRI, along with other blood tests in the form of CBC and biochemical parameters. Next slide, please. So now we come back again to the patient. So it was found that the biopsy showed small cell lung cancer histology. Also, there was CT guided biopsy was done from the liver SOL, which confirmed the metastatic involvement by the disease. On brain MRI, it was normal. You can clearly see the PET CT image and the CT image showing the liver SOL, and so the diagnosis is extensive stage small cell lung cancer with liver metastasis. Next slide, please. So now we come, what should be the preferred choice of regimen? That is chemotherapy regimen, whether we should go for cisplatin versus carboplatin based therapy, and how many number of cycles should be used in our common practice, and what are our views on other chemotherapy regimens, that is irinotecan plus platinum based therapy. Next slide, please. So you can see that this was a study done in China regarding irinotecan platinum combination therapy for previously untreated extensive stage small cell lung cancer. It was a meta-analysis of 9 trials. It was found that the PFS and OS was not better in either arm of the chemotherapy regimen. The EP arm was doing same as the OS and PFS was similar in both the chemotherapy regimens. However, on subgroup analysis, it was found that the PFS was better in the Asian population on with irinotecan plus platinum based therapy. However, in our routine clinical practice, we generally preferred EP based therapy. Next slide, please. So what would be your first line treatment for this patient with extensive stage small cell lung cancer with liver metastasis? So we have options of chemotherapy, which could be platinum plus etoposide based therapy, or we have the option of chemoimmunotherapy, which is platinum plus etoposide plus immunotherapy based therapy. Next slide, please. So in this era of 2023, would you still go ahead with only chemotherapy in first line in small cell lung cancer without immunotherapy? This we are going to discuss in the coming slides. Next slide, please. So when we come to the era of prior to 2018, randomized control trials have failed to show the superiority of comparators to platinum etoposide in first line setting of extensive stage small cell lung cancer. However, post 2018, there has been 2 phase 3 randomized trials of chemoimmunotherapy in extensive stage small cell lung cancer. The first trial was Caspian study, which included durvalumab plus etoposide plus platinum based therapy, which had a median overall survival of around 13 months with a hazard ratio of 0.75, with a decrease in the mortality rate by around 25%. 25% of the patients receiving chemoimmunotherapy. And from this study, it got approval in the first line in combination with EP. Then we have the second study, which is the IMpower 133 study, which is atezolizumab based EP based regimen, which had a median overall survival of around 12 months with a hazard ratio of 0.76, and it got subsequently approval in the first line treatment in combination with EP in extensive stage small cell lung cancer. Next slide, please. So, what should be the preferred regimen in the first line therapy in small cell lung cancer? As Sir has already mentioned that small cell lung cancer is a very aggressive disease. So, we should go for the best treatment option for the patients in the first line treatment. So, if you see around 80 to 100% of the patients are able to receive first line therapy. Subsequently, they go progression. Then from that, only 30 to 50% are eligible for second line therapy. The reason being that most of the patients due to disease progression have a poor performance status, and also as we go from the first line treatment therapy, the best regimens get moved out from the regimen, so the patient get less fit for the subsequent therapy. When we come to the third line therapy, only 20% of the patients are able to receive the third line therapy. So from this, you can clearly say that we should go for the best treatment option for the first line therapy in case of aggressive disease, which is extensive stage small cell lung cancer. Next slide, please. Even if you go for NCCN guidelines, they have clearly mentioned the preferred regimens being either in case of extensive stage small cell lung cancer being carboplatin plus etoposide plus atezolizumab based therapy for 4 cycles, followed by maintenance atezolizumab being category 1 recommendation. Second option, we have the carboplatin plus etoposide plus atezolizumab for 4 cycles, followed by maintenance atezolizumab every 28 days. Either 3 weekly or 4 weekly atezolizumab maintained. However, this is not category 1 recommendation. Then we have the option of carboplatin plus etoposide, or we can even go for cisplatin plus etoposide plus durvalumab based therapy for 4 cycles, followed by maintenance durvalumab every 4 weekly, which is also a category 1 recommendation for all patients. Next slide, please. So today the preferred regimens, as I have clearly discussed, the preferred regimens are carboplatin plus etoposide plus durvalumab, or we can also go for cisplatin instead of carboplatin in the same regimen, or we can go for carboplatin plus etoposide or atezolizumab based therapy. Next slide, please. So what are the criteria that can be considered while choosing the immunotherapy regimen in extensive stage small cell lung cancer? So now we are left with 2 regimens, which is EP plus durvalumab or EP plus atezolizumab, which we are going to discuss further in the coming slide. Next slide, please. So when we look at the comparison of the Caspian study and the IMpower 133 study, you can see that the Caspian study inclusion criteria is reflective of a real world clinical practice, as it allowed either cisplatin or carboplatin based therapy. It also included patients with either asymptomatic, untreated or treated brain metastasis. Also, they compared against up to 6 cycles of chemotherapy with optional PCI in the study, which was not included in the IMpower 133 study, showing that Caspian study had a much more advantage as compared to the IMpower 133 study. Next slide, please. Next slide, please. So now we are going to discuss we are going to compare the durvalumab plus EP in the first hand. This is the only immunotherapy approved to have a demonstrated statistically significant improvement in the overall survival at 12, 24, and 36 months. You can clearly see that the Kaplan-Meier survival curve of the Caspian study is clearly showing a benefit at follow-up of first year, second year, and third year of chemoimmunotherapy regimen. You can see that at the third year of follow-up, 3 times more patients are alive in the Imfinzi plus EP based arm as compared to the EP arm, which was, if you can look at the curve, you can clearly see that at 3 years of follow-up, 6% of the patients were alive in the chemotherapy arm, whereas it was around 18% in the chemoimmunotherapy arm, showing clearly a benefit of chemoimmunotherapy regimen as per the Caspian trial. Also, if you come at the median overall survival, it was 13 months in the Imfinzi plus EP arm as compared to only 10 months in the EP based arm, with a hazard ratio of 0.71, which was statistically highly significant, showing a decrease in the mortality rate by around 29% in such an aggressive disease, which is small cell lung cancer. So, Imfinzi plus EP improved the estimated percentage of patient alive with 3 times more patient alive at 3 years on follow-up. Next slide, please. So now when we come to the comparison of the Kaplan-Meier survival curve of the Caspian study and the IM power 133 study. If you look at the left side curve, which is the IM power 133 overall survival data, you can see the median overall survival is 12.3 months as compared to 10.3 months in the chemotherapy arm, showing the benefit of chemoimmunotherapy regimen as per the IM power 133 study. However, the follow-up was done only for a period of 2 years. And at 2 years of follow-up, the survival was around 22% in the chemoimmunotherapy arm and it was 17% in the other arm. Whereas if you look at the Caspian, which was a 3-year overall survival data, the median overall survival was 13 months in the chemoimmunotherapy arm and it was only 10 months in the other arm. Also on 3-year follow-up, 3 times more patients were alive in the chemoimmunotherapy arm as compared to the other arm. Next slide, please. Next slide, please. So, is 2-year overall survival data is good enough to make the treatment choice for such an aggressive disease, which is extensive stage small cell lung cancer? If you look at the Durvalumab Caspian study, the 1-year overall survival data was 53% and it was 52% in the atezolizumab based study, and it was 23% 2-year overall survival rate, which was around 22% in the atezolizumab based study. Also, 3-year overall survival rate was not reported in the IM power 133 study, whereas it was 18% in the Caspian study. So durvalumab plus EP tripled the survival at 36 months as compared to EP alone. Next slide, please. So now we come again back to the patient. This patient then received systemic chemotherapy, that is cisplatin etoposide plus durvalumab, completing 4 cycles, and post 4 cycles, the scan showed a near complete response and resolution of the liver lesion, showing a significant response with the chemoimmunotherapy regimen. Then the patient was on durvalumab with 4-weekly maintenance therapy. The patient is monitored closely with a serial scan every 3 months with no evidence of progression. Next slide, please. Now we come to the important topic of discussion. Would you recommend PCI and or brain surveillance in this patient with extensive stage small cell lung cancer and almost complete response, which you are going to discuss in the further slides? Next slide, please. So there are 2 studies. One is the European study and the other is the Japanese study. The European study done by Slotman et al. Reported that PCI improved the overall survival. However, the study done by Japanese study, which is Takahashi study, reported no significant improvement in overall survival in the patient who received PCI post systemic therapy based regimen. So although this is divergent data on the utility of PCI in this setting, that is the Japanese data showed no benefit of PCI in patient with extensive stage small cell lung cancer. This has prompted reassessment of its role, whether physician may use it nearly always or not, only in certain circumstances. So there is doubtful benefit regarding the PCI in extensive stage small cell lung cancer post systemic therapy. Next slide, please. So now we come to the whether PCI or brain surveillance in extensive disease small cell lung cancer. So there is paucity of data on the integration of PCI and immunotherapy, as we have discussed earlier, as per the Japanese data, and additional research is therefore required regarding both the safety and efficacy of this approach. So in patients with extensive stage small cell lung cancer without brain metastasis on brain MRI and who can be followed up with regular brain MRI, PCI may be omitted as per the ESMO data, as per the ESMO recommendation, which is a category 2 recommendation. Next slide, please. So now we come to the another important topic, which is radiation therapy in extensive stage small cell lung cancer post systemic therapy. Whether you would consider thoracic RT routinely for extensive stage small cell lung cancer, or in what situation will you consider thoracic RT in extensive stage small cell lung cancer, which we are going to discuss in the further slide. Next slide, please. So now when we come to the role of thoracic RT in extensive stage small cell lung cancer, the CREST trial concluded that thoracic RT should be considered for all patients with extensive stage small cell lung cancer who respond to systemic therapy based on their findings that thoracic RT significantly improved 2-year overall survival and 6-month PFS, but it couldn't meet its primary endpoint of overall survival at 1 year. So greatest benefit of thoracic RT is limited to the patients with residual thoracic disease after systemic therapy with less than or equal to 2 metastasis. So even here, there is paucity of data on the integration of thoracic RT and immunotherapy. This should be explored in further research and further trials are recommended in this. Next slide, please. So now we come to the guidelines, NCCN guidelines. So they have clearly mentioned for response assessment following primary treatment, if the patient has a complete response or partial response in extensive stage small cell lung cancer, they have recommended MRI brain surveillance, can consider PCI or can consider thoracic RT, but these are not clear-cut preferred category recommendations for NCCN guidelines. Next slide, please. Also, when we come to the ESMO guidelines, the ESMO guidelines clearly says that according to the treatment algorithm for small cell lung cancer in extensive stage, if the patient has a good performance status with no contraindication for immunotherapy, the preferred regimen is carboplatin, etoposide, atezolizumab for 4 cycles, followed by maintenance atezolizumab with 1-year recommendation. Also, the other option could be platinum etoposide plus durvalumab based therapy and maintenance durvalumab as the preferred treatment option. If the patient has any contraindication for immunotherapy, then the preferred treatment option is chemotherapy with EP, or you can also go for carboplatin plus oral topotecan or cisplatin plus irinotecan based therapy. And if the response is good, then may consider consolidation. Thoracic RT is an option. And if the patient has age less than 75 years, then you can go for prophylactic cranial irradiation or MRI surveillance, which are both category 2 recommendation as per the ESMO guidelines. If the patient has a very poor performance status of more than or equal to 2, then you can go for chemotherapy with either carboplatin etoposide or gemcitabine plus carboplatin based therapy, followed by further treatment as per the response assessment. They have recommended for best supportive care if the patient has multiple comorbidities with poor performance status. However, the NCCN guidelines do mention that if the patient has a poor performance status related to the disease, then the patient may be given the option of chemotherapy and could be subsequently assessed. If improvement in the PFS, then PS then can go for further systemic therapy. Next slide, please. So now we are going to now we come back again to the patient. The patient is on durvalumab maintenance therapy and presently is on surveillance imaging with brain MRI for brain metastasis. Next slide, please. So now we are going to have a hypothetical scenario. If this patient with extensive stage small cell lung cancer with liver metastasis had brain metastasis as diagnosis, then how would you manage that? So for asymptomatic brain metastasis, we are going to discuss in the further slides whether the patient has asymptomatic brain metastasis or symptomatic brain metastasis. Next slide, please. So the NCCN guidelines clearly says that the patient, if has extensive stage with brain metastasis, if the patient has asymptomatic disease, then you can consider systemic therapy before initiating brain RT. If the patient has a symptomatic brain metastasis, then the preferred treatment option is brain RT followed by systemic therapy, unless immediate systemic therapy is indicated. In case of if the patient has a situation of having difficulty in breathing or deranged liver function test, then we may offer the option of systemic therapy followed by brain RT in that case. Next slide, please. So now we come to the second hypothetical scenario. If this patient with extensive stage small cell lung cancer with liver metastasis had brain metastasis or diagnosis, now what will be your choice of immunotherapy? Whether it will vary or not, which we are going to discuss in the further slides. Next slide, please. So when you look at the Caspian data study, you can clearly see that durvalumab plus EP consistently improved overall survival versus EP regardless of the presence of baseline brain metastasis. Also in patients with brain metastasis, the hazard ratio was 0.69, and in patients without brain metastasis, the hazard ratio was 0.74. So when we look at the Kaplan-Meier survival curve of the patients with brain metastasis, when we look at the overall survival data, the median overall survival was 12 months in the chemoimmunotherapy arm, and it was only 8.8 months in the chemotherapy arm. When we go for when we looked at the other curve, which is the overall survival without brain metastasis, the median overall survival was 13 months, and it was only 10 months in the EP arm. So as we know that this is an aggressive disease, and most probably around 20 to 25% patients present with brain metastasis at initial diagnosis having a significant median overall survival. As per the Caspian data of patients with brain metastasis, the preferred option should be durvalumab plus EP in patient with brain metastasis as per this data. Next slide, please. So when we come to the forest plot and subgroup analysis and look at the brain metastasis subgroup analysis, you can clearly see that in the IMpower 133 study, the patient who had a brain metastasis didn't do better as compared to the placebo arm. So clear cut, this clearly mentions that Caspian study favors the treatment option of durvalumab in cases of brain metastasis small cell lung cancer patient. Next slide, please. Next slide, please. So now we come back again to the patient. This patient received systemic therapy as we have already discussed, and he was on maintenance durvalumab every 4 weekly. So patient has currently completed 8 cycles of
Dr. Suresh?
No evidence. Yes.
Sir, request you to conclude your talk in next 2-3 minutes, please.
Okay. So patient had currently completed 8 cycles of durvalumab with no evidence of progression on serial scan. Next slide, please. Next slide. So now we are going to discuss regarding any role of biomarkers which are TMB and PD-L1 in this extensive stage small cell lung cancer. Next slide, please. So in a small study of 62 patients of small cell lung cancer, it was shown that higher TMB was associated with better prognosis. Next slide, please. However, when we look at the data from the IMpower 133 and for TMB and PD-L1, there was no much benefit of TMB and PD-L1 as a marker for chemoimmunotherapy in small cell lung cancer as per both the forest plot curves. Next slide, please. So this study also showed that there is inconclusive evidence on PD-L1 as a predictive biomarker in small cell lung cancer. So PD-L1 should not be considered as a biomarker for starting chemoimmunotherapy in small cell lung cancer, and we routinely do not advise for PD-L1 or TMB in case of extensive stage small cell lung cancer patient. Next slide, please. So to summarize, my conclusions are that first line therapy with durvalumab plus EP has shown sustained improvement in overall survival compared with a robust control arm. It is reflective of the real world practice as it allows up to 6 cycles of EP and provides flexibility of choosing cisplatin or carboplatin along with etoposide. The benefit with durvalumab plus EP was observed across all subgroups, including brain metastasis subgroup. Survival tripled at 3 years with use of durvalumab plus EP versus EP alone. Durvalumab offers convenient once monthly dosing regimen as a maintenance therapy. Safety findings remain consistent with known safety profile of durvalumab and EP. Next slide, please. So this is the abbreviated PI of durvalumab, that is Imfinzi, and thank you.
Yeah. Thank you, Dr. Suresh, for this extensive talk on Imfinzi, and it's coming in another carcinomas as well in the carcinoma GB, and as we know that small cell lung cancer is a deadly disease. Even adding a 2-3 months in the survival, it's make a significant contribution to the patient's life. So now our next speaker is our dear friend Dr. Jagdeep, which will tell us about the is it the time to target the MET. And although it's a rare mutation, but let's see how is his experience about the MET amplification. Dr. Jagdeep, over to you, sir.
Thank you, Dr. Deepak. And I've listened to the initial sessions, so I'll not be taking much of time, try to wind up in maximum 10 minutes. So, just 1 second. And thanks, Mr. Tarun, for organizing this event along with Mr. Dr. Deepak. And I'll thanks Mark for giving me the slides. So I hope my slides are visible and they're moving.
Yes,
Yes, sir.
Thank you so much.
Make it full screen, please, Jagdeep.
I think it is in
It is full screen, sir.
It's in full screen. Yes.
Okay. Right.
So just I'll be very crisp and I'll be doing in shortly concluding all these things. So this MET exon 14 skipping mutation in adenocarcinoma, it's one of the bad prognostic features, and the patient who are even in the non-metastatics, they tend to have a very poor outcomes in those patients. So I'll be going through this, what of the evidence we have for this MET14 mutations. So to highlight this MET exon 14 skipping mutation in the patient with a small cell lung cancer, and to share the management of these patients, and we have 2 drugs in our basket right now. So disease burden, not going to go in detail. So India accounts for approximately 8% cases in males and 3% in females for this lung cancer, and second most common in males as compared to 7th in the females. And overall, this NSCLC counts for 85% of the lung cancer, with adenocarcinoma being the most common. So alteration in the MET gene, including exon 14 skipping, can disrupt this MET signaling pathway, and ultimately it causes the disruption of the juxtamen domain, which is responsive for the MET ubiquitination, and this increases the number of MET receptors on the cell surface as they are not degraded, and ultimately it causes the increased MET signaling driver oncogenesis. So molecular testing is utmost important, already discussed in our previous slides by my previous colleagues, and even in the our moderating session. And of course, this is the most common is the unknown driver comprising most 1/3, followed by KSRAS, and then the EGFR. And again, the most important thing is the other mutations, ALK, which constitute about close to 5 to 7%. It is followed by the next MET, RET, BRAF, or HER2 mutations or the amplifications. This is the latest guideline from the NCCN, and it clearly demonstrates that you have to do all the molecular testing irrespective the patient, as told by the other guidelines also. And it comprises EGFR, ALK, ROS, ROS1, BRAF, NTRK, MET, exon skipping mutation, RET, and RBP2. And of course, the PDL1 testing, which is again, it's a recommended category 1. And this all profile is in the patient with adenocarcinoma or large cell, non-small cell, not otherwise specified. So these are basically histological subtypes in which we have to do the prompt biomarking testing in the advanced or metastatic settings. So you can do this testing either in this exon 14 skip mutation, either in the tissue available with us, or if it is not available, you can do it the liquid biopsy. So selection of the tissue tumor block, and you have to go for the DNA and RNA isolation, and in case of the blood, you can go with the cell-free DNA or CTC. Asian Thoracic Oncology Research Group, that expert consensus statement, the MET alteration, and they see that the consensus is testing this for MET exon skipping mutation in a patient with advanced non-small cell lung cancer is recommended, and RNA-based methods have been found to be more accurate than the DNA-based. So, of course, the standard or gold standard is the tissue. If we get for this testing for the exons 14 skipping mutation, if not feasible, then comes the liquid biopsy. Due to so many conditions, the patient is not willing. We don't have the previous blocks, or arcing of the blocks is not possible, or the patient is not willing for the repeat testing. So these are the pros and cons of the tissue biopsy versus liquid biopsy. And of course, the most important with the liquid biopsy, easy accessible, non-invasive, and the risk of complication is very few. And of course, targeted collection, you don't need to be, it's just a drawing of the blood and suitable are for patient. But of course, the sensitivity is higher for the tissue as compared for the liquid biopsy. So landscape treatment for this exon 14 mutations is that there are two drugs in our basket, where one is with the Novartis, that's Campatinib, and other is the Merck with the Tepotinib. So these two drugs are there for the patient who are having exon 14 skipping mutations. And it has been seen the patient who received this MET inhibitor as compared to chemotherapy, they have better overall survival as compared to the patient who are receiving the chemotherapy. So this is all the retrospective analysis which has shown in case of 24 patients who were having this MET exon 14 skipping mutations. So you can see on the right side of the graph, so approximately 4 patients had a response, a partial response, with close to some 6 to 7 patients had some stable disease. And with the patients, overall response in the MET exon was just a low at approximately 17%. So MET inhibitors, they achieve up to 67% of the response rate. Even in the patient who had a good PDL expression, if there is a MET exon skipping mutation present, they tend to do a very poor. Though the PDL1 and other EGFR and other ALK or ROS1, they are usually mutually exclusive to each other. But in the MET exon skipping mutations, it has been seen that PDL expression can be high and still they don't do good with the immunotherapy. This is a real-world analysis of the patient with the MET exon 14 skipping mutations, and you can see the median PFS is 2.7 months, and median overall survival is 12.3 months. The patient who received this MET inhibitors. So NCCN as well the ESMO guidelines, they recommend that a patient with the metastatic NCLC, they should be tested for the non-small cell lung cancer for this MET exon 14 skipping mutation, and either Campatinib or Tepotinib, or you can use, if in certain circumstances, Crizotinibs. So, but of course, both the guidelines straightforward says Tepotinib or Campatinib can be one of the drugs in case of the MET exon 14 mutations. So, not going into detail, just going to highlight there are basically both with the Tepotinib and Campatinib, these are both phase 2 trials, Vision trial and Geometry Mono 1 trial. So both endpoint was the overall response rate. The dosing was approximately in this Tepotinib was 450 milligram per day, but in case of this Campatinib, it was 400 milligram twice. So the other drug with which it's still data is not available, it's the result is still studies going on, is Savolitinib. So the most important thing which I would like to highlight in both Tepotinib and Campatinib, that is the efficacy in the first line. If you see the overall response rate is close to 56% with the Tepotinib as compared to 68% with the Campatinib. And in the second line, again, it is 49.5% with the Tepotinib as compared to 41% with the Campatinib. So there are some differences because of the heterogeneity to the population. But overall, if you see the patient who are having this exon skip mutation, they are going to have a good result with the patient treating this MET exon inhibitors. And most important, other important thing is the grade 3 adverse events. When we are all talk of the new drug, safety concern is one of the most important. So Campatinib has approximately 67% of grade 3 plus adverse events, while Tepotinib has only 30%. But the discontinuation rate was seen more in the patient who are receiving Tepotinib. So this VISION trial is a single-arm phase 2 trial in patients with a non-small cell lung cancer who were having this exon 14 skip mutation. Basically, initially it has initially cohort A and cohort B, and cohort A was met exon 14 mutation, B was amplification, and C was basically the patient who had been confirmed of having this exon mutations from the A. They were the confirmatory analysis, and those patients were included in the cohort C. So the later on the result was combined from both cohort A and C, in which dapotenim in the 450 milligram oral dose once a day. And in these, you can see approximately 164 patients were treatment naive, and approximately 1 patient are already treated 1 or 2 lines of previous chemotherapy. So the primary endpoint was overall response rate, and the secondary was the duration of response, PFS, OS, and the safety concern. So this is just the patient characteristics, and the important thing is in these, the 36% had only the liquid biopsy, and as compared to the 42% patient who had a tissue biopsy, and approximately 21% had both liquid and tissue biopsy for analysis. So the tepotinib efficacy in the patient enrolled in this study was overall response rate was close to 56%, with the median duration of response was 46 months, and PFS was 15 months, and again the overall survival was 25.9 months. So this in the patient who has previously treated with the chemotherapy and enrolled, that is in the second line. Again, you said good overall response of 50%, and median for PFS was close to 11 months, and with OS with approximately 20.4 months. So again, going to detail with this patient who having oral efficacy in the patient who either diagnosed with a tissue biopsy or liquid biopsy, the data was robust. You can see both either in the primary first line setting or the secondary line setting, the overall response rate is good. Patient was receiving this MET exon inhibitor. Sorry. So it has been seen the patient with the MET exon inhibitor, the median tumor load of the target lesion, if it is it was 52.9 months in the patients who were having tissue biopsy, and the liquid it was approximately 68. So basically the patient who had gone liquid biopsy, they had a poor disease prognosis because of the median target lesion chosen was 68 millimeter as compared to the tissue, which was 52. So those patients in the liquid biopsy, they had a higher incidence of brain metastasis as compared to the patient in the who are diagnosed from the tissue biopsy. So again, the same thing. This was a response assessment with the neuro-oncology brain metastasis, and it was a composite of the radiographic response, corticosteroid use, and a clinical status, and gives a more comprehensive overview of the patient as compared to the RECIST criteria. And it was seen in the patient with the cohorts A and C that approximately 43 patients with the brain metastasis who were evaluated this RANO-BM score, and that response was approximately 88.4%, and median PFS was 20.9 months. And again, the patient with the target lesion, the overall response was close to 66.7%. So this is just an image showing that when it's a baseline, it was 11 millimeters, and approximately 1.5 months down the line, it is 50% lesion is decreased in size. And again, in 36 weeks, you can see that lesion is almost eliminated. It's a complete response. So the efficacy of this tepotinib in the treatment name, that is in the first line, is quite good. Overall response rate is 66%, and duration of response was not estimated, and median PFS 14 months, and with the OS was again not estimated. So again, in the second line, good overall response rate of 50%, with the median PFS of 12 months, and OS was 20 months. So the most important thing when we are getting to a new drug, so honestly, I don't have any exposure of this tepotinib or campatinib right now. Sorry, one patient of campatinib I treated, but tepotinib I don't have any exposure. So that patient received a treatment for approximately 6 to 7 months, and she had a good response, and she was brain metastasis was already there. So in those patients, the most important side effect was again peripheral edema. Some of the most important was the class effect with the MET inhibitors. but that patient was counseled and was managed accordingly. So safety concern is always a point of concern when we are treating with the new drugs. And again, tepotinib, most important, if you see the adverse events with the peripheral edema, increase in the blood creatinine levels, diarrhea, hypolipidemia, and increase in the ALT levels. So if you say overall, it is the more than grade 3 is close to 40%. Peripheral edema more than grade 3 was seen in approximately 7% of the patient. Sorry, 6% of the patient. And blood creatinine, though it has raised, but it does not lead to any discontinuation significantly. So if you see the patient who received these drugs, there was no any adverse event leading to death. So this peripheral edema, which is seen in the patient with that tepotinib, grade more than 3 was seen in 30% of patient, and 14% of the patient discontinued this due to this adverse event. And this most common, I earlier said with the MET exon inhibitors, is the peripheral edema. So this is one of the class effects, and it occurring the for patient, any patient receiving this MET inhibitors, and it has been seen that there is increase in the plasma, decrease in the plasma oncotic pressure, with an increase in capillary permeability and in decrease in the interstitial hydropressure, which ultimately leads to the edema. So the mechanism of initially this edema are not clear, but may involve inhibition of this MET in the vascular lymphatic endothelial tissues. And this MET inhibitor induced edema may not be immediately symptomatic. It may take time, approximately down the line 2 to 3 months for the patient who are in the tepotinib, and approximately 3.5 to 4 months in the patient with the capmatinib. So you have to monitor for this. Peripheral edema is not life-threatening, but of course it can impact the quality of life. Regular monitoring can be done in the form of the measuring body weight and limb circumference, and special attention has to be given to the elderly patient because of their other comorbidities. Management is usually conservative, dose reductions, and you can also give some of the diuretics. Tepotinib should be interrupted in patient with a grade 3 events and resumed at a dose of 250 milligram once resolved. So it should be permanently discontinued if the grade 4 event, that is grade 4 edema, occurs. So a risk of edema is more in the patient with the advanced stage. So patient with the exon MET exon 14 tend to be older. So peripheral edema occurs more frequently in patients with this subset of groups, and as compared to the other patients. So we have to be more careful for those patients who are getting this drug. I just pointed that creatinine is very common, especially in the first weeks of the tepotinib, but it's mostly mild to moderate, and it's unlikely to be linked to the impaired renal function. And how it happens, basically, there is this MET exon inhibitor, that is tepotinib, that causes the inhibition of the renal tubular transport protein OCT2 and MATE1 and 2. And this creatinine is basically a substrate of these transporter, and it has been observed that there is an increase in creatinine may be a result of inhibition of this active tubular secretion rather than any tubular injury. So if you see in the graph, the grade 3 and 4 creatinine increase is just 0.4%. Grade 1 to 2 is 25%, but it's usually settles with time and does not require any much dose modification in these patients. So of course, creatinine level has to be monitored and managed accordingly. So monitoring creatinine level close to the first 2 months is most important, and this MET inhibitor therapy can lead to an asymptomatic rise in creatinine without an impact on GFR. Therefore, to definitely assess renal dysfunction, alternative measures of GFR can be done. But if the creatinine increase is more than grade 3, and dose reduction or interruption can be discussed. But with grade 1 or 2, usually don't require any dose reduction. And renal function estimate that can rely on serum creatinine should be interpreted with a caution, considering the effect of the tepotinib on these transport proteins. So what is our vision on this MET exon in 14 skip inhibition? Does it becomes a reality right now? So testing, of course, recommended by all the guidelines, should be incorporated in the clinical practice. Patient with MET exon 14 skipping mutation, preferred first line is any therapy, tepotinib or capmatinib, and tepotinib offers a reliable response in patient with the MET exon 14 mutation in small cell lung cancer with or without brain metastasis, and has additional dosing convenience. Thanks for your patience listening to me. I know this has already taken a time, and I stop my steam. So.
Yeah, thank you, Dr. Jagdeep, for this very rare and important mutation. I have no experience with the MET mutation, and I never seen that. And hopefully, in the coming future, when these rare mutations are becoming common, so we will be able to see this mutation, and hopefully that these molecules will be available to our country, and more and more people will be affordable. And secondly, now we are doing it NGS quite often to the majority of the patient, because the Indian generic of NGS are plenty in the market.
So that's why means when the patient, like in the stage 3 stage 3 lung cancer, even sometimes I have seen the patient getting done the molecular testing, even not means not in the metastatic settings, but it just gives a prognostic mark. MET exon, this mutation is a bad prognostic marker. So patient tend to do poor with any of the chemotherapy lines or even with the immunotherapy. So if this drug, I told you I had experience with the Tapatalum was not available at the time. Of course, finance is a big constraint to those patients. But it was a good experience with that patient. I did not require any significant reduction in those patients. That patient.
Okay. Great. Yes, great to hear that. Okay, thank you so much. It's already been
Thank
9.
you, Deepak. Thank you.
Good night, Dr. Deep. And I would like to thanks all our esteemed speakers and our panelists for their sparing this valuable time on the Friday night. And thanks to the organizer, Mr. Mathur, for this and Gitika for this webinar. And I again thanks from my bottom of my heart for the for your participation and valuable contribution. Thank you. And